real life.
Good evening. Welcome to the webinar, Walk-in Child with a Cloudy Cornea. This is a clinically relevant topic. AIOS conducts periodic webinars, in fact, every second Saturday, on a clinically relevant topic aimed at general ophthalmologists and subspecialists. Today, we have this webinar being moderated by Dr. Muralidhar Ramappa, who is also the program director. He has put together a nice series of topics relevant to this subject and also an eminent panel. The chairperson for this webinar today would be Dr. Samar Kumar Basak, who is the president of AIOS, Dr. Ken Nischal from the University of Pittsburgh, Pennsylvania, USA, Professor Radhika Tandon from the RP Center for Ophthalmic Sciences, AIMS, New Delhi. Muralidhar, of course, will be the moderator, and helping him will be Dr. M. Vanati from the RP Center for Ophthalmic Sciences, AIMS, New Delhi. She's also the editor of Indian Journal of Ophthalmology. We have an eminent panel, starting with Dr. Arif Khan from the Cleveland Clinic, Abu Dhabi, UAE, Dr. Asim Ali from the University of Toronto, Canada, Dr. Anil Kumar Mandal, close home from LV Prasad Eye Institute, Hyderabad, Dr. B.S. Ramamurthy from Srinivasa Ultrasound Scanning Center, Bengaluru, Dr. Deepak Edward from University of Illinois, Chicago, Dr. Merle Fernandez from LV Prasad Eye Institute, Hyderabad, Dr. Meena Lakshmipati from Shankanethralaya, Chennai, Dr. Revati R. from Aravind Eye Hospital, Coimbatore, Dr. Ramesh Kekunaya from LV Prasad Eye Institute, Hyderabad, and Sushmita Kaushik from Advanced Eye Center, PGI, and of course, Vinay Gupta from RP Center for Ophthalmic Sciences, AIMS, New Delhi. So this more or less covers the entire spectrum of ophthalmology, all the causes for cloudy cornea. And this is the program that we have for today, and I request Murali to take over and run the show.
Thank you so much, sir. At outset, I would like to thank particularly Vanavo for giving me this opportunity to put up this program. And he also helped me choose this very fantastic title, Cloudy Cornea Walk-in Child. What do we think of? How do we triage and how do we manage such cases? So we have a stellar faculty with us today. So I'll, without further ado, I'll request Dr. Ken Nischal to deliver his keynote address. Thank you, Dr. Ken, for sparing time and being with us this evening.
Thank you so much. I'm going to share my screen straight away so that we can get going. I want to thank you very much for organizing this, and Professor Hanover for asking you to do this. It's, I think, going to be very helpful and very interesting. I hope you can see my slides. Please interrupt me if they're not moving forward. Thank you. Okay, so I'm going to talk about global consensus on definition, classification, diagnosis, and surgical staging. These are my financial disclosures. None of them are relevant to this talk. I read this recently, and I think it's very, very pertinent for us as scientists and doctors. You must always be willing to truly consider evidence that contradicts your beliefs and admit the possibility that you may be wrong. Intelligence isn't knowing everything. It's the ability to challenge everything you know. So with that in mind, my journey on this started in 1998 when I was at Toronto working with Dave Rootman and Alex Levin. And this was a study we published where 40% of the clinical diagnosis that we made in congenital corneal opacity children was incorrect once you did the imaging. So on your left, you might see something that you might want to call sclerocornea, but when you do the UBM, it's keratolenticular adhesion, which, as you know, is often called Peters anomaly type 2. So this is started the road of investigation, and there were many, many publications from my group looking at these problems. And I finally came up with this classification, which has been further refined. So I'm going to share that with you. There's, according to this classification, primary corneal disease and secondary corneal disease. And the secondary corneal disease that I'm not going to talk about is the acquired secondary corneal disease, the one, you know, the metabolic, the trauma, the infectious keratitis, the non-infectious keratitis, and the miscellaneous, you know, keratoconus, the rare xeroderma pigmentosa. But if you look at corneal disease in children as being primary, all of those are developmental, then secondary, which have a group that are developmental, and then a bulk that are acquired corneal diseases. I'm not going to talk about the acquired corneal diseases today, but it's important to remember that they play a large part of a child walking into your clinic with a cloudy cornea. It may well be an infectious keratitis, but I'm not going to talk about that today. So when you look at primary corneal disease, the first group are the corneal dystrophies. As you know now, there's only one congenital hereditary endothelial dystrophy. It's what we used to call type 2 due to compound heterozygous or homozygous mutations in SLC4A11. And children should be tested for hearing problems because there's a higher incidence of hearing problems in CHED due to that mutation. And then there's posterior polymorphous dystrophy, which can occur at birth, as in this child, and the histology is showing the multi-layering of the endothelium and the epithelial characteristics of that endothelium with the cytokeratin stain on your right. Well, we know that surgical intervention does well. When I first started looking after these children, I was doing penetrating keratoplasty in the early 2000s. But now, of course, you can do an endothelial keratoplasty and get a very good result. So surgically, the primary corneal diseases where it's due to corneal dystrophy, they do well. And what you're looking for is, as I showed here, it can be a very cloudy cornea, but you're not going to have an increased corneal diameter. They're not going to be tearing because they haven't got harpstry. So it's important to make sure that you understand that you may not be dealing with a congenital glaucoma. It may just be a corneal dystrophy. So the next one that I want to talk to you about, and before I talk to you about that, is this condition, this term sclerocornea. All of these 6 children were referred to me with sclerocornea. So what does sclerocornea mean? And even within the genetics literature, they call this Midas syndrome or MLS, and the S stands for sclerocornea. But you can see that sclerocornea can't be everything, right? There must be a problem if we're using one word for a diagnosis for several different things. And I want to remind you, and this was a paper that my group did, and when you look at the phenotype, it's variable. And when you see, I can imagine why somebody would have called figure D here sclerocornea. I understand that. But it's incorrect. When you look at the UBM, there is a secondary congenital aphakia. So without understanding what the cause is and just calling everything sclerocornea doesn't help. So we could call it congenital corneal opacity, do the imaging, and then you're able to define what you're dealing with. And in some of our cases, we had keratolenticular adhesion here, which again, you can call that Peters anomaly type 2, but without defining what's going on, it becomes impossible. Now, there will be some of you in the audience who are saying, well, we don't have a high frequency ultrasound. Okay, this image here in F is not a high frequency ultrasound. It is the ultrasound that your anesthesiologist uses to find a vein. You can use that for a very short time, as long as it's less than 15 megahertz, and get that image that I'm showing you in F that clearly shows that there is no lens. So you don't need fancy equipment. The equipment that you need is already there in your hospitals, as long as there's an anesthesiologist putting children to sleep in your hospitals. So I always use this figure. I feel like we use the term sclerocornea to make any foot fit the glass slipper. And I'm sick and tired of being one of the ugly sisters. I do not want to fit the foot into the glass slipper when it doesn't fit. Okay, what about corneal structural defects due to dermoids? Oh, I've jumped. I'm actually going to talk about CYP1B1 cytopathy. I'll come back to dermoids in a minute. So CYP1B1 cytopathy, this was a paper we published. We basically showed that in a whole cohort of children with congenital glaucoma due to mutations in CYP1B1, there was a group that did not have an enlarged cornea, and they had a cloudy cornea that did not improve after the glaucoma was treated. And they didn't have HARB-3 either. And this is another one of papers that my group published about the variable phenotype that you could see in these opacities. Essentially, what you're seeing here is missing decimase and endothelium centrally and Bowman centrally, but peripherally it's present. In other words, this is what von Hippel described as von Hippel's ulcer. And when you read his original paper, he described this in a child with ophthalmos. So over 100 years ago, they described the phenotype of glaucoma with this missing decimase and endothelium and Bowman centrally, but not peripherally. What you're seeing at the bottom here is if you have an opacity due to a HARB-3, it looks different. Bowman's is present centrally, and then you see the HARB-3. So this opacity is not due to HARB-3 or neglected glaucoma. They do well surgically when you do the graft, but their glaucoma is very severe. So let's talk about dermoids. What I want to show you is that when you have a dermoid that's extensive, even if it goes down to 200 or 250 microns, we published this paper showing that you can use the SLET described by Verinder Sangwan and his group when he was at LV Prasad, and actually you get stromal regeneration. I don't have time to go through it right now, but you can read the paper, and it shows for dermoids, you don't need to be doing lamellar keratoplasties. You can do this procedure as long as the depth is no more than 250 microns. This is a typical dermoid, right? You all recognize this as being due to Goldenhaar syndrome, but there are dermoids, other dermoids, that are due to rhizopathies. These pictures are courtesy of Andrea Molinari. I have my own pictures, but I love this because it shows the waxy alopecia of this child. And then these children, they do well if you do a graft because the dermoid is just affecting the cornea. The anterior segment is untouched. Then you see dermoids like this, which are fat, flat, and reticular. This is due to trisomy 8 mosaicism. So let me make the point right now. You can use the term dermoid, and it can refer to all these three. I'm not saying that we should throw the term dermoid out the window. I am saying we should refine what we describe as the phenotype. So the dermoid on your top left is a typical limbal dermoid with hair follicles growing out of it. On the top right, it's a fibrofatty dermoid that's invading the cornea. And at the bottom, it's a reticular dermoid. You see how the phenotype changes. So what about secondary developmental? Well, iridocorneal adhesions, we know that this is called Peters anomaly type 1. I don't like that phrase. Why? Because it doesn't tell you what to do. It doesn't tell you. And in fact, it can be misleading. I'm going to show you. You could call this Peters anomaly, but you would say iridocorneal adhesion with no intraocular involvement of the lens, right? And what we know is that these children do well surgically if you do a PKP, but you can do an optical iridectomy, and they do very well. You don't have to do surgery in terms of a PKP. And I'm going to show you more novel systems coming up. So have a look at this. This is my algorithm of when a child presents with a neonatal corneal opacity, what do I do? And you can see that doing nothing in terms of intervention is definitely a possibility depending on what the eye looks like. But I'm going to just walk through some examples here. Here's a case, 5-month-old boy sent to me from San Francisco, other side of the country, and we evaluated him. And this is mild, right? It is mild, but it's affecting his visual axis. So as you know, there was almost simultaneously two groups, Murli's group and George Mehta's group, started to describe selective endothelial removal for Peters anomaly. Now, what I do is I do an optical iridectomy and I do the selective endothelial removal at the same time. And this is a paper that Murli very kindly involved me in. So there's plenty of data there. This mother lives on the other side of the country. And you can see that over a period of, I think, 12 weeks, the opacity cleared. But then I got this boy, 6-week-old. And if you look at the imaging, now you've got this excavation, right? And that excavation is often seen by a clearing centrally. If you try to do selective endothelial removal here, you could end up making things worse, because the template, the way selective endothelial removal works is you take away the diseased endothelium and the healthy endothelium from the clear cornea grows in. But if you don't have a template for it to slide across onto, what you could do is just damage stroma and cause stromal fibrosis. So this kid gets corneal transplantation and he does well. Why? Because his anterior segment, the lens is not involved, and he just has iridocorneal adhesions. So bilateral Peters anomaly, and yet 2 different surgical approaches, because we don't have to get rid of the term Peters anomaly, but we have to define it like we did dermoid. Peters anomaly should be defined as no excavation, but iridocorneal adhesions, or excavation with or without iridocorneal adhesions, with or without lenticular adhesion. Again, we're trying to fit a foot into a glass slipper that doesn't fit. Sometimes the lens fails to separate. How can we say that this is the same Peters anomaly? In this particular case, the lens was inside the cornea when we looked at the histology. How can we possibly say that the prognosis for these cases is the same as the one I showed you with iridocorneal adhesion? And yet, we call them Peters anomaly. So what I'm saying is, when a child walks in and it's a neonatal corneal opacity, call it what you want, but define it by imaging so that you understand what your options are. This child has the lens attached, and we know that when you do a corneal transplant in a child who has a lens attached, the survival rate goes down. This child also has something called Peters plus syndrome, which I'm going to show you. So I ended up doing an iridectomy, and the child can see now. This child has so many other problems that you don't want to have to take them back to the OR again and again after doing a PKP. So we talked to, my group published about the ocular phenotype of Peters plus syndrome. And what I want you to notice, the gene is a glycosylation gene. So look at the excavation. There is clear evidence in the mouse model that there is a glycosylation deficit that causes the posterior stroma almost to melt. It's not a proper melt, but it doesn't form properly. So my wish is that we understand the molecular biology of these cases better, so that, like the retina folk, we can actually start to think about molecular therapies rather than surgery. I bet you that if the retina folks could do retinal transplants, they would never have got into molecular biology. It's because we can do corneal transplants that we have been lazy and not gone into the molecular biology. But I think it's time now to get into the molecular biology. So here's one where the lens fails to form. And again, if you do a transplant, it's going to be tricky. Here, if you see a silver cornea, you've got to be worried. You've got to be worried. It's normally primary congenital aphakia. But don't ignore these children. You've got to put a tube in their eye to control the pressure. Otherwise, they'll turn up at the age of 12 in your clinics with spontaneous ruptures. You also want to give them aphakic glasses because the stroma is thin, and look at that transillumination at the bottom. Just do a trial and error until the child suddenly thinks that they can see better. So don't abandon these children. And they're usually due to mutations in FOXE3. Okay. This is the most pertinent picture I can show you. This mother rang me on a Wednesday, said, I live in, she lived in one of the states on the other side of the country, and said, I've been told my child has Peters anomaly and they're going to do a corneal transplant on Monday. Please, can you see my child before then? So I see the child, and look, There is no disruption of the Descemet's membrane. The anterior chamber is flat. And I took the child to the OR and I removed the lens. And when I removed the lens, it became clear that this was a case of PHPV, where the plaque at the back had pushed the lens forward. And I did the lensectomy. Now, the child still had this opacity, but now they're aphakic, and you've avoided a graft. But look, if you use the term Peters anomaly without defining what is the cause, you are going to damage children. This paper I wrote about cataract surgery in children with congenital keratolenticulaar adhesion, the editor would not publish it, or the section editor, without me putting Peters anomaly type 2 in the title. Extraordinary. Okay. In the original Cinderella story, written by the brothers Grimm, in their version, one of Cinderella's evil stepsisters cut off her toes and the other heel, so they both fit into the tiny glass slipper. And I put it to you that that's what we're doing. Every time we use terms like sclerocornea and Peters anomaly, it doesn't matter what the child has. We want it to fit. And it doesn't matter what damage we do to the child's eye while we do that. Unfortunately, the nomenclature for CCO is stuck, and it affects our understanding and therefore our outcomes. I'm going to share with you an anonymized email I received this week. And the person says, I must agree with Dr. XXX, Peters anomaly. Let us not throw the baby out with the bathwater. The term has served us well for all our professional lives. Yep, it certainly has. Dr. Peters deserves his recognition and preservation as having shown us this anomaly in such cogent detail. 1906, he wrote that paper, Dr. Peters, 118 years ago. So I think that if we can do a deep phenotype, we can then go into all the different options. If there's disease stroma but a healthy endothelium, we can do a DALC. If it's a large corneal dermoid, you might be able to do a removal with SLET. You might have to do a lamellar keratoplasty. But unless you define what you're seeing, you're not going to be able to tell. So, deep phenotype, Peters anomaly, sclerocornea are not appropriate terms on their own. If you want to keep them, then we have to refine them. And primary and secondary corneal disease is a good way to approach these kids. I want to invite everyone to take this QR code. The International Congenital Corneal Opacity Network has been launched. If you would like to be a part of it, then all you have to do is go onto the WSPOS website, fill in the page, and we will be contacting you in the next 2 or 3 months so that we can all try and deal with these kids better. Thank you.
Thank you, Dr. Ken. As usual, fantastic lecture. And you made a lot of sense and making that clarity, using a new versus a old terminologies. The old nomenclatures not only at time confusing, they're also misleading, as you rightly pointed out. So in your armamentarium, so how do you, prioritize, investigations like OCT, UBM, and molecular screening? How often you do the molecular screening in your practice?
So, Murli, I'm very lucky that in Pittsburgh, I have dedicated ocular genetic counselors. So every child that comes in is evaluated with me and them. And we managed to get testing done, usually a whole exome, on all our children. Some of our children have already had it because they're coming from another referrer, another ophthalmologist. But our hit rate is not high. I would say that only 15% of all the children we test with the congenital corneal opacity, actually we find a gene. And the reason for that is that I think that there are final pathways that cause the opacity, regardless of what the gene is. And my group at the moment are defining those pathways. So one of them is the glycosylation pathway. So there could be a gene that affects the glycosylation pathway that we're not aware of at the moment, and you'll get that excavation phenotype. But I would say that if you see a child and they have a cleft lip, they have very short arms, they have that kind of central corneal opacity, that's Peters plus syndrome. But that's a very specific syndrome. You can get Peters anomaly with systemic features, but that's not necessarily Peters plus. But the way, even within the area of genetics, this idea of Peters anomaly and sclerocornea has crept into their diagnoses and then nomenclature, and that's fine. But when you say Peters plus syndrome, it's a very defined opacity that you're talking about. Sometimes it can be very mild, but often it's quite severe, but it can be mild. So the answer to your question is when they first see me, they all get a linear ultrasound scan. I have one in my clinic. They all get a full evaluation by me. If there's any worry about dysmorphology or the child is not gaining weight, they get a renal ultrasound scan and a cardiac echo, and then they'll go and see a pediatrician. But those are the first things I do. And they also get a VEP and an ERG on the first visit. All the OCTs that I do, I don't have swept source OCT, so I can't do it quickly. So I do that under anesthetic, and all my patients get an EUA.
Thank you, Dr. Ken. Other panelists, any questions to Dr. Ken? Any comments, questions?
Ask one question.
Yes, Dr. Meena, go ahead,
Yes,
please.
I want to know the role of ERG in patients with congenital corneal opacities, and I have personally not used them. And when do you do VEP?
So, I do a VEP in everybody. And the reason why I do the VEP is sometimes you have a young child with opacities that look the same, and parents can't tell you which eye sees better, or they're not sure. So my philosophy has always been that if I'm going to do a corneal transplant, because it's a total corneal opacity, I always like to do it on the worst eye first, so that if something goes wrong, you haven't taken away the overall function of the child. So I use the VEP for that purpose. I also do the VEP because if I do a flash VEP and it's very poor, then it doesn't matter what you do to that child, the prognosis is poor. And you have to make that very clear to the parents. The ERG I do because very occasionally the ERG will be abnormal because of chorioretinal scars. I showed a picture of the MLS children, the microphthalmia with linear skin defects, also known as Midas. And there was one of the children, we had done the ERG and it was very poor and I didn't understand. When after I did the graft, you could see all these chorioretinal scars and they were affecting the macula as well. So that's why I do the ERG. Normally the ERG is supranormal because you get scatter of light. So your ERG is, it's normally supranormal, super big amplitudes and good ERGs. But if you see one that is abnormal with low amplitudes or even flat, then again, I said doing nothing is okay if the prognosis is poor.
Thank you.
Can I ask a question?
Hi.
Hi. Is it like the same described previously as anterior segment dysgenesis? Because there you get angle abnormalities also. So
Yes,
in cases must be having angle abnormalities also.
Yeah,
And
I think the terminology, and so the only reason I don't use the word anterior segment dysgenesis is that in genetics, there is an actual condition caused by PITX3. So if you're talking to a geneticist and you say, this is anterior segment dysgenesis, they go start checking for PITX3. So I use the term anterior segment developmental anomaly. ASDA. Unfortunately, in the United Kingdom, ASDA was a grocery store. So you have to be careful when you said ASDA to the parents. But I agree with you. I think a general terminology like of anterior segment dysgenesis or anterior segment developmental anomaly is more helpful. And then you can start to define it as you're able to image the child. That's my opinion.
May I ask a question? Ken, hi, it's me, Vinay.
Hi, Vinay.
Yeah. Could you tell me how do you rule out glaucoma in these children? Like, how do you measure intraocular pressure? I mean, what are the parameters you're using to rule out glaucoma?
Yeah, I'm so glad you've asked that question. Vinay, I just got a referral yesterday of a child who has a clear congenital anterior staphyloma. The baby can't close the lids, and the mother told me that the local doctor said that the pressure was normal. They used the eye care, and any instrument, when you have congenital corneal opacities, is not reliable. It doesn't matter what you use, because the cornea is not normal. The cornea is not 550 microns thick. So I rely on axial length and digital palpation. Those are the two things that I know will tell me. And I can tell you, this child, I got the child, when the mother phoned me, I rang the local doctor. I said, just do a B scan and send me the B scan. This child is 3 months old. The pressure is 11. The axial length is 24 millimeters. Right? So people measure pressure, but don't think about the fact that it's not a normal eye. So I use serial axial lengths. I rely heavily on digital palpation. Even after I've done a corneal transplant, I will use the eye care because it's easy, but I correlate that with the axial length and digital palpation because I don't think it's reliable. It's different with children who've had corneal transplants for other reasons, like, when I do DALCs for children with MPS, or when I do PKPs for children who have very severe corneal endothelial dystrophy, and they're very young. I've got no space to do an endothelial keratoplasty. But I'd be interested to see what the other panelists say about that, because I think it's a very, very pertinent question.
Yeah, we agree with you, Dr. Ken. We also use a surrogate measures, as you rightly said, horizontal corneal diameter and a serial axial length, apart from digital, tonometry. Dr. Sushmita, you have a point, please.
Yeah, so Dr. Ken, we do exactly the same, and we actually have the symphylosis graph in every chart of the child. And because just the axial length may not be enough, that child, that especially in CPA, depending
Yes.
on how much the ciliary body is atrophied, some children have microphthalmia, some children have ophthalmos, depending on the balance between ciliary body and trabecular meshwork, I think. So
Yes.
we always look at the growth more than the absolute axial length and over a period of time. And even if it is lower or higher, if the growth is similar, then I think we don't. And we are not as brave as to put in a tube. What we use is a very limited DLCP with transillumination, maybe a quadrant at a time. And yes, we give them +10 glasses or FAK glasses.
Yeah. So I used to, when I first started my first case in 1999, I did transscleral cyclodiode laser, like you said, but I used UBM to try and find where the ciliary processes were. It's very difficult. What I found was, Stuart Brown taught me this. He said that everybody worries about putting a tube in children because they think that these children are normal. He said, but their vitreous is not normal. And if you put a tube in, it will not get blocked. And he was absolutely right. Their vitreous in congenital primary aphakia is not normal. And I know that because, unfortunately, when I first did my first PKP in one of these kids, there was no literature about it. So I did it, and the vitreous was it was like water. It was unbelievable.
Yes.
And of course, I don't do PKPs on them anymore because those 3 cases that I first did, they all went thisical within 6 to 12 weeks because these membranes form. So I have put tubes in, and I think I had, out of all the tubes that I put in, I've only had one where the eye actually went thisical after putting the tube in. But I'd warned the parents it might do that.
Thank you. Next, I'll invite Professor Radhika Tandon. She will be speaking on unraveling the code. You can upload your slides.
Yeah, good evening, everyone. As Santosh and Murli said, that they would like sort of a simplified version of all the principles that we know as experts to share with the common audience so that they get a clue as to how to handle a patient of congenital cloudy cornea. So with the knowledge that we have with advances in ocular research and intervention, everything we do is eventually trying to make things simple for everyone else. But unfortunately, with this particular area, it's still very complex even for us. I will say that greater information available through molecular genetics has given a kind of a pathway of categorizing things more clearly. But at the same time, we have to remember that whatever one does has to have a holistic approach, and it does require multidisciplinary. Even within ophthalmology, we have the glaucoma specialists, we have the pediatric cornea specialists, and then we have people who are specifically doing the genetics of these diseases. So we have to integrate our information from basic clinical and applied experience to try to sort of unravel the code for everybody else. One cannot forget that there are unique populations in India, and apart from the fact that the very ethnic and the genetic makeup is unique, it's also another complexity comes in because often people do not come straight away. The parents are not able to bring the child straight away. So you see the child a little way down the disease pathway when things become a little more complicated because there may be associated manifestations which are making it a little bit more difficult to be sure what it is. So a little bit about what experience we've had in trying to unravel the genetics of corneal disorders. I'll give a brief snapshot of what work we did about 20 years ago when we were first able to start this work in this field. That time, Dr. Preeti Paliwal was doing her PhD under Dr. Arundhati Sharma, and I was a co-guide for this work. And we looked at the distribution of corneal dystrophies in the North Indian population. There was data available from South India, but there was a paucity of data from North India. And basically, it's not that one would say that there would definitely be a difference between North and South, but there can be because there are different patterns of consanguinity and also different ethnic makeup or sort of genetic makeup of the populations. So as a corollary to that, we also look specifically at the endothelial dystrophies. And as you can see, you have the endothelial dystrophies, and then you have Fuchs, and we have CHED. And here again, we, as I mentioned before, sometimes the patient presents so late. So there was actually a 45-year-old lady who presented with features which were very puzzling. And it actually turned out she was a case of CHED. So that is really, really very unusual to have a 45-year-old lady who had come to the age of 45 without having any keratoplasty done. And eventually at the age of 45, she was finding life difficult. And then we went ahead and did the PK and also did the genetic testing. The other thing is that in our population, in this sort of series that we studied, we had noticed that 39% of patients were familial. And then here again to highlight when you're talking about an endothelial disease, how you have Fuchs, we have posterior corneal involvement, and then we have CHED, and how with the greater knowledge of genetics as well as the study of the genotype and phenotype, we realize that it's just the endothelium after all, but there are so many different ways in which the disease manifests in the cornea. Now coming to the concept of a cloudy cornea at birth, now this is the example of the lady who had actually come very much later. So she was 40 plus, and we have had a few more patients who've actually been detected over the age of 20. So they've got these additional features. There's this iron line, there's spheroidal degeneration. And we have not been seeing any bullae occurring in our patients of CHED. And of course, you have thicker corneas and you might have this kind of appearance on OCT. So I was just going back to the initial thing when we're talking about a cloudy cornea at birth, that is fine. We will go over how we differentiate, but I should not forget that there are a lot of variations in the extent of that cloudiness, the threshold of the parents to bring the child in terms of how much they find the child to be abnormal. There are variations in the abnormality or the extent of the abnormality in the patient per se. And then there's a further complexity of, socioeconomic concern, sort of challenges, or being far away from the hospital, not being able to come, and so on and so forth. So looking at the our particular that small cohort we studied 20 years ago, there were 35 subjects from 28 families, and we again found the mutation, and we found that there was a relatively lower occurrence in North India compared to some of the South Indian studies. And there was a higher degree of consanguinity among the patients, but this consanguineous relationship was among cousins rather than verticals, because the pattern of consanguinity is different in different parts of the country. So here it was among cousins. But still, though we know it's a genetic disease, no mutation was found in 21 patients. So this is the pattern of mutation that we found. There was one novel mutation found in 2 patients, and the other were all known mutations. But again, the manifestation is the same, but the mutations are different from person to person. So we have not had that much of ability to see if the extent of presentation, extent of cloudiness, etc., was different according to these different mutations. And the other thing is we tried very hard to see if there was any other thing that could be identified, but no, we couldn't find any other mutation. So therefore, there's definitely a genetic heterogeneity and overlapping. So this was funded by the Department of Biotechnology. And where did we go after that? So over time, we have, of course, tried to improve our knowledge, and we read Ken's papers and the concept that how old-fashioned terms of sclerocornea, Peters anomaly, etc., are not appropriate. And we do agree that a lot of these things are very pertinent. So we also tried to see what is the clinical and diagnostic profile of the patients who are presenting to us at RP Center. And this was then done with as part of the thesis of Dr. Ananya Kaginalkar. And we did use these words in the protocol because these are the various sort of nomenclatures which are present in literature, textbooks, journals, and so on and so forth. And of course, there's a multidisciplinary approach which is required, but largely in ophthalmology, I would say cornea and glaucoma is very, very interlinked. And despite having such expertise available at hand, again, we sometimes do land up with challenges simply because of the late stage or the sort of variable presentation of the patients. So we try to make some sense of all this, trying to combine the clinical photo, corneal topography, OCT, UBM, and confocal microscopy. And here again, I want to emphasize, because the key is, it's not a question of in a tertiary care center, we ourselves sometimes are having challenges, though we have the best of expertise available. But what happens to the periphery? So can we put our expertise or lack of expertise together in some way and come up with some kind of a simplified solution that we can share, so people at the periphery can, learn to organize their thoughts and then, give a more kind of a simplified version of what it is. So largely, we tried whether we could use AI to differentiate these infantile corneal opacities. And as Ken mentioned, there are certain conditions which one is quite easy to differentiate. But we found that sometimes there can be an overlap. And again, it may seem ridiculous because the diseases are completely different. And I have kept the word Peters here again, the reason I explained is because that's the term which has been used throughout. And we're considering the spectrum, and then we want to define further the additional features which are present to characterize, rather than just put it as a basket diagnosis of Peters. And this work was done about 5 years ago, 4 or 5 years ago, and now we stopped using the Beers Peters, and Ken, I'm sure, will be happy with that. And we use the term anterior segment developmental anomaly for this group. So there are the three broad categories. And of course, if you have a genetic analysis, then it's all right, because then that gives you a clear path, irrespective of what the phenotype is. You know, it gives you like, this is the code and this is what it is. And the phenotype may be different because various reasons. But it's not always that you do have a genetic analysis. And the question was, getting it tested is also a challenge and it is expensive. So we wanted to see that, can we have a kind of a clinical correlate that will tell us that, okay, if it looks like this, then it's, the genetics is likely to be this. So unfortunately, that didn't work out that well. So it's not that simple. And it could also be because in the previous study, we had found that there are a good percentage of patients where the genetic test just didn't reveal any mutation. There is a heterogeneity. But yes, we found certain things useful. The age at presentation, anterior segment developmental abnormalities present a lot earlier. Chet tends to present a little bit later. It may be because they have some degree of vision and it doesn't look so drastically abnormal to the parents. And they also looked at, so the age at which they present was definitely significantly earlier with the anterior segment development anomalies. And then we also looked at the corneal status, so looking at the corneal diameter. And this was a clear giveaway. So the moment the corneal diameter is large, it goes definitely in favor of primary congenital glaucoma. However, I will show you some examples later on where you have a combination, where you can have CHED with a secondary glaucoma. So looking at the horizontal and the vertical diameters, and UBM was again extremely useful. Now, again, as I mentioned, the idea was not to say that everybody needs to purchase a UBM in the periphery, but we were trying to say that with our access to a UBM and everything else, can we somehow use AI to come out with a simple algorithm which can be applied? And so if somebody doesn't have a UBM, but they have the parameters, they can have some direction. And here the key thing is glaucoma, because we do not want people to miss glaucoma. That requires very, very early intervention. And the others may, you could refer the patient a week later or 2 weeks later, but if they have glaucoma, they need to go straight away. So that was the idea of this study, and we also looked at the genetic analysis to see if putting this information could give some clarity. And here is an example of the various details that we had. But of course, the number of cases is still small. This is the work in progress. This is to emphasize that childhood as such requires, even healthy children require special care. It's more difficult, and whatever intervention you do, it's going to have a lifetime of implication. So the intervention needs to be very judicious. This is an example where there was a 10-month-old child who underwent surgery, and having a correspondingly young donor. So using this kind of input, we're also trying to see what happens with the long-term prognosis. This was another 7-month-old who was diagnosed as ASDA, had the keratoplasty done. This is the case diagnosed with CHED, but this is what I meant about how they may present later, because they do have a cloudy cornea. Parents may not think of, because they think that they have slightly bluish eyes and they may not have may not look that grossly abnormal. And so these children may present 3, 4, 5 years. And also originally when we were doing keratoplasty, and these children had maybe 5/60, 6/60 vision, they were playing normally and were not sort of visually compromised in the day-to-day playfulness or activities. So at the time of PK, there was a little bit of hesitation whether you need to intervene. But now that we have DSEC with better outcomes, one is less reluctant to intervene. And if the child even has reasonable vision, but one would then want to go for a better outcome, and one would consider a DSEC. Here's another example of a monocular child who was operated, and this was a congenital corneal opacity, and then had operated PK. Now, this patient is another example of ASDA, and histopathology, the report came as sclerocornea, but that's because at that time in our form, we had filled in sclerocornea. And this child is now 8 years old, and our policy has been to operate on one eye. keep the other eye as spare because they were traditionally known to have poor prognosis. However, this very young girl has now come at the age of 8, and the initially operated eye is doing well, and the mother was very keen to get the other eye operated. So now she's undergone the other eye surgery, and 1 year post-op is maintaining good vision in both eyes. So to sum up, I would say that document everything possible. Characterize all the details you have. Try your best to get the genetic analysis done. And regarding a simplified AI solution, it is a little far away for now, but we hope that with more diligent data gathering and analysis, we hope that there should be something available in the near future to help people in the periphery. So with that, I'll stop here. I hope you enjoyed the talk. Thank you.
Thank you, ma'am. Very informative presentation. You made it very simple for a general audience. I have a question here. It's my personal dilemma for the last 10 years. Monoocular cases, other eye being absolutely normal, they insist for a penetrating keratoplasty, new generation parents. And I can tell you from my experience, having done about close to 120 such surgeries, and although good number of, I have had anatomical success, but not the functional success. They give up after some time. They not compliant for the patching, amblyopia therapy. So I just wanted to take a group consensus here. When you have a child who has other eye is absolutely fine, is it appropriate to operate and keep that cornea clear when you have a low functional outcome? I will start with Dr. Radhika.
Yes. So traditionally, we've always had the concept that keratoplasty has a poor prognosis in children, and definitely monocular patients, one would then not hesitate to operate because as such, even the operated eye may end up in a very terrible situation. However, I would say that over the last 4 or 5 years, certain changes in our protocol have made us a little bit more confident of getting good results with keratoplasty in children. So I will definitely not offer it as a surgery, but if the parents are very keen, I would not refuse. And regarding the occlusion, earlier we were again very particular that it should be I find that if you have some vision and you give them occlusion for half an hour, 1 hour, 2 hours, and then you sort of build it up gradually, often the parents are a little bit maybe more educated now, or everybody in the country is changing their perception. So the parents who are even from poor socioeconomic backgrounds, who have taken the effort to come for a monocular case, I feel the ability to take care of their children, I feel, has improved compared to how it was long ago. But having said that, yes, they do sometimes come with trauma. As the child is sleeping in the same bed as some 2-3 other people, and then an elbow hits it, and then you feel terrible because then they come with a graft dehiscence, and you feel, it would have that eye would have been tectonically more stable if it hadn't had a graft. And the same trauma, if the child had sustained without the graft, wouldn't have come with this situation. So I would say that it definitely, you need to put it all in the knowledge of the parents, all 1 to 10, and then let them take a decision, and then you support them rather than you dogmatically telling them this should be done and this should not be done, that kind of thing. Engage them in all the risks. Sometimes, of course, you do make errors despite all one's effort, and parents also may take the wrong decision. But largely, I think the caution is important, both in terms of vision and also the integrity of the eye.
Yeah, great points. My biggest concern is that child has to endure several anesthesias and impact of, this anesthesias over a long term. That was my biggest concern. Dr. Ken, you have any difference in opinion here?
No, I think I totally agree with what Professor Tandon just said. I try to do, if I can do an optical iridectomy with selective endothelial removal, I will prefer to do that. But if it's a total corneal opacity, but the other eye is completely normal, I don't push the surgery. But if the parents come to me and say, we want surgery, and the prognosis appears reasonable, then I will do it. The only thing I would say about patching, when a child has a unilateral opacity, like a unilateral cataract, the chances of them having latent nystagmus, manifest latent nystagmus, are much higher. And I learned this when I was with John Elston in Oxford almost 30 years ago. When a child has latent nystagmus, if you patch them for half an hour, just like when we test their vision degrades. If you patch them for 4 hours, that opacity oscillation reduces, and then they start to get faster rehabilitation. So if I have a child with latent nystagmus, I patch them 1 whole day per week, not hours per day. And it becomes easier for the child because they know that this day is the day that I'm going to have the patch, and then the other 6 days, I'm good. And the most I've done is 2 days a week, but I found that the rehabilitation of the vision is better, faster.
Thank you, Dr. Ken and Radhika. I'll invite the next talk would be by Professor Sushmita. She'll be talking on what to look for in a congenital cloudy cornea.
I think it needs to be unshared possibly. Dr. Radhika?
Dr. Radhika, if you could unshare your slides, please.
Right. Is it visible now?
Yes, madam, it's visible. You can go ahead, please.
Right. Thank you. So at the outset, of course, thank you very much for the opportunity to be in this august panel. And I feel a bit of a left out, an outsider, because my concern would be glaucoma. And I'm glad that that got a mention. So the outline, of course, is, as all clinicians and surgeons, we would, when a baby comes like this, we would want to know what is under that white cornea and a little bit about what we learned along the way. So when we have childhood glaucoma, they often present with this cloudy cornea, which is similar on the surface, but it really has countless hues beneath. So the background is that there are various types of corneal features that we've just seen, and you could have ranging from corneal edema, scarring, Harb's striae, corneal opacities with central clearing, and it sometimes becomes difficult to get through what is actually happening, and we'll just see what we've done to make this a little easier. So this is our approach to children with a congenital cloudy cornea and glaucoma, and the clinical clues and investigations. So the commonest that we would get with an absolutely cloudy cornea would be an acute hydrops because of raised IOP and the Descemet's membrane, which tears when it becomes large enough to stretch on either side. Then, of course, we have fluid in the stroma, which is what it comes. And this is the easiest really to pick up. And sometimes the Harbs can really be any configuration and any direction. They can be crisscross, concentric, vertical, though the traditional teaching is vertical tears are because of forceps deliveries. But we've seen really all kinds in all directions. And an extension of that would be a mother who's distraught and says, he was perfectly fine 2 days ago and look what's happened. And for a glaucoma surgeon, it's like, yes, because this is the one which I know is just a stretched Descemet's, which is there. And if treated in time, this is the one that will do really well. So just a couple of days of an anti-glaucoma and you can already see it clearing. And then when you go ahead with surgery, we used to do only a combined trap with trap, but now with this amount of clearing, I can do a GAT easily and they clear just as well. So this is one of the most gratifying congenital corneal opacities for a glaucoma surgeon if you have an acute hydrops in PCG. One interesting thing we noticed was that there must be something predisposing to acute hydrops, because we saw a couple of children, they come with acute hydrops, we do the surgery, it clears, and in a couple of weeks they come back with acute hydrops in the other eye, and then we need to do surgery in both. And we saw this in a few, not too many. So now of course, COVID taught us to do bilateral surgery, so that's now taken out of the equation. But at the time when we reported this, we weren't doing bilateral surgery, but acute hydrops was the one condition which made us do a goniotomy or something in the other eye, and then we didn't have the sequential acute hydrops, as it were. So another one is the diffuse corneal cloudiness, which is present since birth. And if on a UBM and the deep phenotyping, there is nothing else except a homogeneous haze, which is bilateral, there's loose epithelium, is thick cornea, and it's likely to be a neonatal onset PCG. Again, this prognosis is good, because if we operate in time, they grow up to be nearly normal children. So they clear very well. Coming to what we've talked about, cloudy cornea with a central clearing. So when we see this, at least from a glaucoma standpoint, my heart really sinks, because I know that this is the kind of punched out defect that isn't going to clear no matter how much I bring the pressures down. And usually, of course, we use a UBM in every child of glaucoma during the EUA. And it can come in various forms. And this is a baby who came with PCG in one eye and Peters in the other. So the PCG eye, of course, clears beautifully. But the Peters, what we do is we just do the surgery and then do an optical iridectomy in the clear cornea that remains once the edema goes. It's not always just a defect. I know Dr. Ken just showed a baby, and this is a similar one, where the entire lens is in that huge Descemet's defect there. So these are the eyes which really don't do well at all, and we know that. But the UBM helps us prognosticate that if you have a lens which is sequestered in the cornea, this eye is unlikely to do well. So it's helped us a lot in prognosticate. So I'd like to share something new that we learned, that all central clearing may not be Peters. So this baby was diagnosed as Peters because of the central clearing. And yet on the UBM, we showed a large intracorneal cleft, but there was nothing on the Descemet's. So if the Descemet is perfectly normal and the rest of the anterior chamber is normal, this is something that we've seen. And what happens is, even if you bring the pressures down, if I see a cleft, I can prognosticate to the parent that this cleft is not going to clear. So this is a newborn who came with these large things. We thought it was Peters, but she had both. And interestingly, once the pressure was reduced with surgery, of course, the cleft only comes down and the rearrangement doesn't become clear. But there is this little bit of defect which remains. The cornea remodels. But of course, this child also has 2 optical iridectomies awaiting a PK if it can be done. So this is something that we've learned as another prognosticator for what's going to happen later. Again, like Dr. Ken talked, our gamut of sclerocorneas, we've learned about congenital primary aphakias. This was the first one which I operated, and as Dr. Ken said, the vitreous was like water and it just flowed out, and in 4 weeks' time, this eye went into phthisis. On reviewing the UBM, I realized this was CPA, which I'd missed, but now I know what to do. And now this guy, this little baby, is now about 5 years old, but just with +12 glasses, he's walking around. He even goes to school, though he sits on the first bench. So this is one eye, bicycle, but one eye, at least we've made him ambulatory, and at least he walks around and it's okay. So then the journey continued because we recognized so many more. This is a boy who came in. We asked, do you have any more children? Yes, we have a little daughter. She's exactly the same. So they had almost the same UBM picture. We know that now. This is thanks to Murli's paper. We've learned so much that these children really, with their plus glasses, they look into mobiles, they look at cartoons. They are pretty nice in the clinic. So we've learned what to do that. And when we retrospectively reviewed sclerocorneas, which we all put into one folder because we realized that 5 babies more really were congenital primary aphakia. Now we can diagnose them clinically. We do something called flying baby ASOCT. This is the ASOCT. It takes 30 seconds for us to just pick up the CPA now, and we don't need to take them into the OR and do the UBM for diagnosis. It's never simple. Sometimes you can have corneal clouding since birth, but on the EUA, we found a cloudiness in the lens as well. And when we did the UBM, it actually was a nuclear cataract. So when we tested the baby, it was IgM positive for rubella, and we realized that we live in a country where rubella vaccination is not universal. We prospectively looked at all our newborns, and the best thing and the thing that came out of it was if you have an eye which is small, then you need to be careful of rubella, because our rubella babies had smaller axial lens. There were cataracts in 10 of 13 of them. There were cupped discs, so there were glaucoma as well, and the corneal diameter was also smaller. The cornea never clears. These babies have no way to get a chink of cornea for an optical iridectomy, and they all require a PK. And we contrasted them with babies who were rubella negative, and you can see how the neonatal onset glaucomas without rubella clear beautifully, but the rubella keratopathy doesn't allow them to clear. And more importantly, there are systemic associations. We actually look for them in neonatal onset glaucoma now, and at least 3 of the 7 in this study required surgery for a PDA, which we'd never have thought of. And we also look for hearing defects, and 14% had them. So just to finish a story, this is a 4-week-old girl, and the parents brought her in because her elder brother, who was about 1.5 years, had been operated for glaucoma elsewhere, and they said it hadn't made any difference at all. And he was also rubella positive. So that was a double whammy. I mean, we didn't know what to do now. Is this a rubella keratopathy, which is why does she also have it? And then there was no limbal stretching. There was no Harb striae. The pressures were 12 and 13 without medication. And even though the media was hazy, the cup to disc ratio was just 0.2 to 0.3, so pretty normal. So again, CORNEA came in, and it was very interesting that we had a very, very nice trabecular meshwork shadow, and the iris was inserted into the ciliary body. And this is the one of the boy, and this is the little girl. So CORNEA with a flying baby is so useful to us to even know whether there's something going on in the angle. And we just got a genetics for her, and sure enough, she was SLC 4A11. So now the CORNEA ASOCT for us has become another ally for diagnosing children with congenital corneal opacities. And of course, not all cloudy corneas are developmental conditions. This is one who came with a fingernail injury, and the UBM showed an adherent glaucoma with the lens up there. So she, of course, required a management of a very different kind. So to summarize, corneal clouding in children with glaucoma is a significant concern, but early detection and intervention are crucial to prevent permanent loss. Challenges are in diagnosis, and we need to rely on clinical science, imaging, and of course, genetic tests as well. But as everybody said, we require a comprehensive treatment approach, close monitoring, and family education. Thank you so much for the opportunity to.
Thank you, madam. Fantastic talk, and a lot of new learning pearls for all of us. And I have a question, that intrastromal cleft.
Yes.
Did we look for a CYP1B1 mutation in that particular cohort?
Yes. Most of them did have a CYP1B1 biallelic homozygous recessive CYP1B1. Those are the ones which usually have, and they end up with what Dr. Ken calls a CYP1B1 cytopathy, so that spindle-shaped opacity remains. So we phenotypically learn to recognize that, yes.
So these cases, we have very carefully done a UBM, but I failed to elicit any communication into anterior chamber.
Yes.
How do we explain that cleft, large cleft, as you rightly said, even after a trap surgery that will persist? And these are very extremely poor cases for a penetrating keratoplasty. I generally resort to optical iridectomy in all these cases. So any difference in opinion?
Yeah, I just think that the aqueous has all gone in, and then it has sort of pushed the stroma in all sorts of directions and have just accumulated there because there's no way to get out. So there's no defect as such, but like we see in acute hydrops, there's no defect. But if we leave, I'm just wondering if we left the acute hydrops and didn't operate, would they finally form a cleft because I think it's such a large Descemet's defect. But in the baby that I showed, when it remodels, all of them scar. So when I see a cleft, it is so important that I prognosticate the parents that, look, this cornea is not likely to clear. So this to us has been one of a very new learning thing, because we diagnose them all as Peters. Dr. Ken came to our clinic once and said, if you see a central clearing in a white opacity, it's Peters. And when we looked at the defects when we acquired the UBM in the OR, we suddenly saw that not all of them had defects. Most of them did, but some did not. That's all.
Dr. Ken, since you have published almost 15 years ago this particular entity.
Yeah, so it's a glycosylation deficit. So we are very, very close. I've been working with an excellent molecular biologist. Actually, he's from India originally, at the Children's Hospital, and we can create those clefts in animal models.
Okay.
And it is a glycosylation deficit. So it's like you need glycosylation for all your lamellae to form. And there's an anterior lamella and a posterior lamella within the cornea. At the junction of the two, depending on what the deficit is, you either get a posterior excavation or you can get one in the anterior stroma, and that's where you get what looks like a cleft. It's not filled with, from what I can see, the ones I've seen, they're not filled with fluid, but if you manage to get the whole cornea and send it and ask them to stain it for glycosaminoglycans, it stains like the glycosaminoglycans in MPS. But it's not MPS, obviously. So I think that actually your paper was very helpful to us when we were trying to see if we could recreate that phenotype. And it's a really, really nice work. So congratulations. But you're right. If you see the cleft, it's not good news. So the only one that we actually had a genetic cause that was clear, wasn't CYP1B1, was digenic inheritance. We published this where a child had a FOXY1 mutation and a PITX2 mutation, and they got this huge cleft in the stroma. So that's the only one that we had the genetics on.
Next, I'll invite Dr. Mandal. He shall be talking on corneal eye drops in PCG. Dr. Mandal?
Yes. Okay. Good evening, everybody. Thank you, Dr. Murli, for including me in the speakers panel. So the title of my talk is Hydrops in Primary Congenital Glaucoma, the Surgical Management. Here is a picture taken at presentation when the child, the parents walk into the emergency of our institute in the afternoon. Actually, in the noon, the patient developed sudden corneal clouding in the left eye and the child was crying. We saw the patient and felt that it is acute hydrops related to infantile onset glaucoma. How it happens actually, there is Descemet's membrane which is having a break, and this is because of interplay between the enlarging corneal diameter and elevated intraocular pressure. And water goes, or the aqueous humor goes into the corneal stroma and gives rise to acute corneal hydrops. So this is the patient whom we operated in the very next day. I'll come to the surgical technique later on, and the later picture, 6 months postoperative appearance. Here is the HAB striae, which is photographed under fundus retroillumination. Now, just coming to the differential diagnosis of Descemet's membrane. In any case, detailed evaluation should be done. And we can see there are several reasons which can give rise to acute corneal hydrops. So here is a situation. The patient came after birth, after 2 hours of birth, after forceps delivery, the patient was referred to our institute with this condition. Actually, this was not glaucoma, it was forceps injury. You can see the line along which the cornea was folded. This is 6 weeks postoperative appearance of the patient. And here is 2 other patients with birth injury, which can mimic congenital glaucoma. Here is different types of Descemet's tear which can happen and can give rise to acute corneal hydrops. Here is a patient where, because of primary congenital glaucoma, combined trabeculotomy, trabeculectomy was done, but because the dissection was not proper, it has led to corneal Descemet's tear, and which later on patient required repeat surgery for control of intraocular pressure. Keratoglobus and keratoconus can also give rise to corneal, acute corneal hydrops. So just to talk about the surgical treatment, we do primary combined trabeculotomy and trabeculectomy. Under a partial thickness scleral flap, limbus based, a gradually deepening incision is done to incise the superficial wall of the Slem's canal, as it is seen in the video now. Once the endpoint reaches, there will be slow ooze of aqueous, and then the trabeculotomy is done with the help of metal trabeculotome. Once 90% of the probe is in the canal, it is rotated to disrupt that segment of the trabecular meshwork, and the same thing is done on the other side to complete approximately 110 to 120 degree of the trabeculotomy. At the end of that, trabeculectomy is performed, and you can see the result.
So the voiceover is not audible, sir.
Voice
Maybe
is not there?
Yes, maybe we can skip
Okay,
that.
we'll go ahead.
Yes.
We'll go ahead. So here is the postoperative appearance. This photograph was taken 6 months after the surgical technique, and the results are dramatic. We published this in the photo essay section of in New England Journal of Medicine. The child completed 13 years of follow-up. This photograph was taken at the follow-up of 10th year. I presented the publication to inspire the child for doing medicine in future. Look at the picture. At presentation, 10 years postoperative appearance of the left eye. Cornea is apparently clear, but when we did the endothelial study, you can see the endothelium of the afflicted eye is so poor compared to the other eye, which is absolutely normal. Cell count, the quality, the clinical appearance of the cell margin, hexagonality, polymegathism, and all these qualities are afflicted in the affected eye. We did a study, 199 eyes, which underwent endothelial study, revealed that endothelial cell count is decreased and the quality of the endothelium is poor in the afflicted eye. This patient underwent cataract surgery later on, developed cataract surgery. About 2 weeks, about 2 years ago, I did the cataract surgery. You can see the cataract surgery is done with clear corneal cataract extraction just in front of the blade. Small air bubble is injected and the staining of the capsule is done, and then capsulotomy is performed with the bent cystitome, and then the cortical matter was totally soft. There was no nucleus, so the cortex can be removed with the help of Simcoe's cannula. You can see. At the end of the irrigation aspiration of the residual cortex, we could put the 13 millimeter overall diameter lens in the capsular bag. The child had visual acuity of 20/40 before the development of cataract. After cataract operation, patient regained the visual acuity. So some of the patients will require corneal surgery or even cataract surgery in the long run. So just to talk about the series, during my work on first 23 years from 1990 to 2012, we could collect 38 eyes of 31 patients who underwent combined trabeculotomy, trabeculectomy for acute onset glaucoma related to acute hydrops. Corneal diameter ranged from 11.5 to 14.5 millimeter, and all the patients presented with corneal edema. However, corneal clarity was restored in all the patients. Yet another example, 4-month-old child presented in the emergency as acute hydrops in the left eye, and you can see 1 month postoperative appearance revealed clearing of corneal edema, and you can see the HABS trial. The child completed 7 years of follow-up. This photograph was taken at the end of 3rd year follow-up. So good intraocular pressure control was achieved, and visual acuity 20/60 or better was achieved in 44% of the patient. The most common refractive error was compound myopic astigmatism. Because of the corneal enlargement, because of the Descemet's tear, most of the patient will have astigmatism. And you can see the first child I presented, and along with this child, the parents as well as the neighbors felt that the child is having beautiful eye. So baby's beautiful eye, beauty or the botheration. Sometimes it is manifestation of infantile glaucoma or congenital glaucoma. Bilateral presentation, more severe in the left eye. However, right eye also had acute onset. You can see 6 months postoperative appearance showing total clearance of corneal edema in the right eye, but in the left eye there is residual corneal clouding in the area of HABS trial. You can see this is the right eye which was having milder form of the affliction, and in the left eye which was having more severe form of the disease. Bleb appearance with primary combined trabeculotomy, trabeculectomy without any mitomycin appears like this. I do not prefer to use mitomycin in primary surgery because of the obvious reason, I believe. So this series was published in the journal. What I wanted to tell in this picture, a patient who presented with acute corneal hydrops in the left eye, corneal diameter was 13 millimeter in the right eye and 13.5 in the left eye. On anesthesia examination, we realized that the patient will require surgical intervention in the left eye, but the right eye had intraocular pressure of about 18 millimeter of mercury and cup disc ratio was 0.3. We operated on the afflicted eye, but started anti-glaucoma medication in the form of topical dorzolamide 3 times daily, carbonic anhydrase inhibitor, and postoperatively, patient did very well. You can see the HABS tie in the left eye, but we explained the situation to the parents The parents, both the parents were doctors, and we explained why we started the medicine in the right eye. And in fact, we explained that the right eye in future may also require surgery. To my surprise, the parents called after a week of left eye surgery, the right eye also developed acute hydrops. We called the patient and did surgery on the other eye also. So even in unilateral affliction or unilateral presentation, the other eye should be evaluated very carefully, and the possibility of medical treatment or even surgical treatment should be explained to the parents. And all these parents, all these, I'll say family members should be discussed that we should be able to treat the child. It requires lifelong follow-up. And even in so-called unilateral cases, the other eye should be followed up very carefully for the manifestation of glaucoma damage in that unafflicted eye. So this is a process which requires lifelong follow-up of these patients to make the patients see well and do well in their life. Thank you.
Thank you, sir. Beautifully describing eye drops. And sir, in our series, what percentage of the cases had a persistent corneal edema despite of the good control following a trap?
So I have analyzed about 15 to 20% of the patients, even when the corneal clarity is intraocular pressure is controlled, corneal clarity is not, really normal. So some of the patients do take longer time for clearance of corneal edema, depending on the severity of the disease. We wait for 3, 4, or up to 6 months to get a final situation to really decide on anesthesia examination, on repeated examination in the office also, to realize when the children will require intervention from the point of view of corneal grafting. Yes.
Thank you, Dr. Mandal. I'll request Professor Asim Ali to deliver his talk. He shall be talking on a preoperative evaluation, critical period assessment, and timing of surgical intervention. Thank you, Dr. Ali.
Thank you. Thank you for the invitation. And there's been some really wonderful talks. I think I'm going to be covering a lot of the same interventions, so hear some of the same messages as well. But what I'd like to speak about today is really about the early onset congenital corneal opacities. There'll be some examples in the pre-op evaluation of opacities in children that come with cloudy corneas a bit later on, but I'll speak about that. So this was sort of touched on earlier in terms of the pre-op evaluation of children who present with congenital corneal opacities. And the complete eye exam includes the fundus exam, pressures, corneal diameters, and imaging, I think, is extremely important at the first visit. And we've had some discussions about, evaluating the back of the eye, looking for, masses, things like persistent fetal vasculature. I'll speak more about UBM and OCT as well. And it's very important to make sure a systemic assessment is done. As has been discussed already, many of these conditions may have other abnormalities, especially cardiac abnormalities. And I always like to make sure that there's a good primary care physician or pediatrician, ideally who's involved in these cases, especially for the cardiac abnormalities. You may also want to have a geneticist as well if there's suspicion of other concerns. Imaging, I think, is a key part of what we do. And again, it's been brought up before. It helps to establish a definitive diagnosis. It helps to analyze the phenotype. And I think the phenotype helps to guide your management. The surgical planning has been discussed. If you know that, for example, the lens is going to be in the anterior chamber or is adherent to the cornea, that's really important if you're going to do a penetrating keratoplasty. I think it's also very important for prognosis, and I'm going to speak more about that. A lot of our work has looked at the prognosis of having, for example, adhesions of the lens in the cornea or glaucoma, and this is really important for the family. And if you can give them that information at the very beginning, it also helps in the selection of what type of procedure you're going to do. It helps to make it real to the family what types of challenges you're going to be dealing with. It also helps with training residents and fellows. And I think all of these assessments can be performed awake. And I like to have all of these assessments done prior to an EUA. And I usually defer the EUA to the time of surgery if surgery is going to be done. So an eye like this, whatever you may call it, the important thing is knowing sort of what lies beyond those cloudy and opaque corneas. And we talked a bit about persistent fetal vasculature. This is another example of what Ken was speaking about earlier, where there's a congenital corneal opacity associated with a lens abnormality, in this case, persistent fetal vasculature, and a corneal transplant is not the way that you deal with this. You need to deal with the lens issue first. It also rules out situations where there may be detachments, other abnormalities as well. And it sometimes can tell you about the presence of a lens depending on how it's done. UBM is really very helpful. There's been a lot of discussion about primary phakia, which is this case in the far right, where you may see just some residual lens or no lens at all. And in the far left, you can see that there is a lens present, even though there's not much of an anterior chamber. And this type of case is actually associated with a pretty reasonable prognosis. These are other examples, and what you can see, clefting, and you can also see these depressions within the cornea, iridocorneal adhesions, and again, the presence or absence of the lens, and also whether the lens is adherent to the cornea or not. And you can see here, greater severity, cysts, and at times you can also see the CYP1B1 type of abnormality. OCT gives you, I find, gives you more information with regards to the adhesions between the lens and the cornea. It also gives you an idea of whether there's decimase present or not. And you can see in the top picture there, you see a small area where there's a keratolenticulated adhesion. And sometimes in these cases, and Ken's published on this, you can just divide the lens away from the cornea and perhaps get away without a corneal transplant at all. At the bottom, this is a case of a congenital anterior staphyloma. And in this case, you can see that there's iris tissue, uveal tissue lining the cornea. And this is going to be managed, again, very differently than a case with a regular congenital corneal opacity. These modalities are also helpful for other conditions. At the top, there's a child with a polymorphic corneal dystrophy, posterior polymorphous corneal dystrophy, and then at the bottom there is a patient with a scar, and these are going to be managed obviously entirely differently. Sometimes you can see this pretty easily at the slit lamp. Sometimes in the younger children, it's easier to either use a handheld OCT or was shown earlier, like the flying baby technique, with a conventional anterior segment OCT. I was asked to speak about the critical period, and we do know that earlier correction of an opacity gives you better visual outcomes, and the problem is that with corneal surgery, this can come at the expense of greater complications. So one of the examples that many will use is that of congenital cataract surgery, in which the trade-off is amblyopia versus glaucoma, and early surgery is associated with better visual outcomes, but also a higher risk of glaucoma. And depending on your practice, the optimal timing is around 6 to 8 weeks roughly, sometimes a bit longer for bilateral cataracts. And it's not common to operate on a child, for example, at 2 to 4 weeks anymore. But in these cases, the rest of the eye is normal, and that's not the case in children with congenital corneal opacities. So it's very important to not apply the cataract criteria to congenital corneal opacities. There is an effect because of the degree of opacity. As we've seen today, not all opacities are exactly the same. And some in children with congenital corneal opacities can often have surprisingly good vision if nothing is done to them. And you can see children, for example, being able to ambulate, identify colors and large shapes. And sometimes it's better not to operate. Do we really need a strict cutoff for the timing of procedures? And I would argue that's not the case. So if you're doing a penetrating keratoplasty, the real pro of early surgery is less amblyopia, but there are a lot of other trade-offs in terms of the technical difficulties associated with early keratoplasty. The tissues become more rigid over time, the iris becomes easier to handle, and there's less posterior pressure. So you get better anatomical outcomes and graft survival with later surgery, and potentially less glaucoma, although that's not well defined in the literature. So the trade-off here compared to cataract is amblyopia versus graft failure and potentially glaucoma. So the one thing to keep in mind, if you have a dense congenital corneal opacity, you do not use the cataract norms for all the reasons that I mentioned, but also that if you do a repeat graft, it's more likely to fail. If you do cataract surgery, earlier on, you get, for example, visual axis opacification that's easy to fix. But if you do multiple corneal transplants, they're not likely to work. We'll often do, for a dense congenital corneal opacity, we'll do surgery at 3 to 4 months or later, and we'll address the glaucoma and the cataract separately. And we'll talk, conservative measures have been mentioned today, and definitely things like optical iridectomy are good options. This is our schema for children with the Peters anomaly, and I do still use the type 1 and type 2 nomenclature. But I think the key point is that if you do have a child with a peripheral or paraxial opacity, and you manage them with pupillar dilatation, optical iridectomy, the visual outcomes are actually better than in children with penetrating keratoplasty. But sometimes you're forced to do that because an optical iridectomy is not appropriate because of a large central greater than 3 millimeter corneal opacity. When the lens is involved, the prognosis for a graft decreases. And if it's possible to either separate the lens or do an optical iridectomy, that will generally do much better than doing penetrating keratoplasty at the same time. And if there's no lens or lens remnant, that's not really Peters anomaly, that's really primary aphakia, then you probably don't want to be doing keratoplasty at all. We've looked at this over a long term. If you can see the scale at the bottom for survival curve, this is in graft survival in children with type 1 without lens involvement, or type 2, which is either cataract or keratolenticular adhesions. And you can see that over time, the survival for the grafts with the lens involvement drops off where it stabilizes in children with type 1, and quite acceptable, sort of over 70% in those children over 18 years, roughly. Order of procedures is important. So for graft longevity, many authors have shown that if you minimize other procedures at the time of transplant, you can improve graft survival. As already has been discussed today, control the glaucoma first, and make sure that that's under good control before you consider doing a transplant. If you need to remove a cataract, ideally, if it's possible, try to do it before or after the transplant, unless you're forced to because there is an adhesion between the two. There are a lot of, when I speak to people who don't do, a lot of pediatric cornea, there's reports of, these combined procedures with people doing, glaucoma, cataract, and corneal transplant at the same time, and in the belief that the early clearing is extremely important. But in these cases, you'll get late failure, and you're less likely to have a clear graft. The effect of glaucoma on the corneal transplants can't be overstated. And this is another look at the data in our cohort, showing that if you do a penetrating keratoplasty and the child does not have glaucoma, and these are all patients with Peters anomaly, the survival rate for graft is well over 80% over many years. But if glaucoma is involved, the graft survival rate drops off very precipitously. This doesn't entirely apply to staging the procedures, but it does tell you how important it is to manage glaucoma in these patients that have both problems. The timing of surgery in, for example, patients with CHED or posterior polymorphous corneal dystrophy, these are less amblyogenic, and we've already had some talks about adults with CHED and reasonable results. We always like to exclude glaucoma, and it's important to remember that glaucoma can coexist with this condition as well. If we have a very dense corneal opacity, not like the one at the top, but maybe more like the one at the bottom, will operate somewhere between 4 and 12 months. And this is really dependent on the degree of opacity. Definitely children with less cloudy corneas can go well into childhood with very good vision and good results at a transplant at a later time. So just to summarize, I think the prognosis in these congenital corneal opacities is very phenotypic specific, and it's important to know the prognosis and be able to use that to help guide your selections and inform the parents. The timing of the surgery does depend on all of the things that I've mentioned, and tailor to each child, so there's no firm cutoff. And we do know that better outcomes can be had with later surgery, although this may sacrifice some vision for better long-term success. Thank you very much.
Thank you, Dr. Ali, for a very beautiful message. We should not use a pediatric cataract template when particularly dealing with pediatric corneal disease. It's well taken. Are there any questions, comments in terms of the timing of surgery, interval between the two eyes? Dr. Asim, what is your interval between the two eyes, first and second eye?
If they're very symmetric, then if we're going to be doing the same procedure on both, and I'm not talking about optical iridectomy, I'm talking about penetrating keratoplasty, it's usually within a few weeks, just so that I can take the sutures out at around the same time, and just minimize the total number of anesthetics. So usually it's within about 2 weeks or so. That's more for practical reasons and to minimize anesthetics. I don't have any other reason to do that. I don't know what others do. What do you do? So
yeah, I do the similar, between 2 to 3 weeks between the two eyes. That allows me to gauge how first eye is doing in terms of healing everything, and also I would assess how committed parents are, and then I'll go with the second eye.
Right.
Dr. Maul?
Yeah, so I actually initially was doing it at around 6 weeks, and then realized that the patients who've had surgery done at 6 weeks, the second eye was always weaker in terms of the visual recovery. And so then I shortened that duration to around 3 weeks, and I feel that the outcomes are better that way.
Thank you. Dr. Ken, Dr. Radhika, you have any additional points here?
Yeah, I found as time has gone on that if it's bilateral, symmetrical, dense opacities, that I try to push the surgery out to 4 months, 5 months, and then I will do 2 weeks spacer. If one eye is much more affected or the vision is much worse in one eye than the other, then I do the graft, and when that eye becomes the fixating eye, then I do the other eye, so that I know that I'm not operating on the better eye before I never want to operate on the better eye.
Sure.
So what I found was that what I lost in terms of the critical period, I gained in terms of less complications and having to take the child back to the OR. I'd be just interested very briefly. One of the things that strikes me is the rates of infectious keratitis, even in the United States, in these children. And, when do you guys stop putting Pred Forte or dexamethasone drops in the eyes? Because most of my children have a drop at least 3 or 4 times a week, even 2 years after the surgery. But I'm struck as to how often we get infectious keratitis situations.
I think
So
go ahead, Dr. Maul.
Yeah, so what we realized was that if all the sutures are out, I think the chance of infection and rejection were highest in the first year.
Yeah.
After that, it comes down substantially. And I think if we usually switch to loteprednol. I don't know if you have that available in the US. So that
we
helps
do.
us because we avoid all the problems that you get with prednisolone. And I think keeping the surface healthy is something that helps. So we've got a lot of patients who've got these tarsarophies in situ, and that helps because the surface doesn't break down so much. So that's some of the things that we do.
I haven't seen as many infections. I mean, we also use loteprednol as well for long-term prophylaxis against rejection, but I haven't seen too many infections. The only time I used to see a lot of infections was with contact lens use. So if they're aphakic, for example, they get glasses, I won't use contacts. Those are the patients that we've seen infections. Maybe I'm just very lucky. I haven't seen a lot of infections in the PK patients. Unless they have glaucoma, and then that's a different issue.
I have a question.
Sorry, go ahead. Sorry.
Yeah. So since the panel has both cornea specialists and glaucoma specialists, so when you order an EUA, how many of you prefer to have a glaucoma specialist along with you when you prognosticate and plan for surgery? Because for me, the main problem will be glaucoma. So if you're doing UBM and you find that there is more than 270-degree pass, now do you and your glaucoma colleagues take a call as to what is the best option now? Because that's the main reason of doing an UBM, to see the peripheral anterior angles, to see the position of the lens, and to look at the anterior chamber depth. So I just wanted your opinion if you do change your options of glaucoma surgery first, transplant, or how soon the glaucoma surgery follows the transplant. I hope I'm clear.
I think some of us, I mean, I do my own glaucoma. I know that Ken does as well. And so, I don't have the communication, talk to myself, I guess. But I would always do the glaucoma first. You really shouldn't be transplanting an eye unless you have some emergent reason to do so. You really need the glaucoma under good control because you will kill the graft off very, very quickly. And I would rather wait until, however, the glaucoma can be controlled and I'm very comfortable and confident before I'll do a transplant.
So sometimes you get normal intraocular pressures despite the angles being not open. I do not know what to call those angles because I'm not seeing those angles. They're not open fully, neither are they closed. There is a dysgenesis. So how do you approach a phenotypically a Peters anomaly with a angle anomaly, with a normal pressure? So are you going to space those EUAs far more frequent, or are you adding an anti-glaucoma medications post-operative?
When you say there's a normal intraocular pressure, doesn't mean anything to me.
No,
what's the axial length doing?
Whatever I'm going to get on the Perkins, and of course the age-rated and axial length is normal for that age.
Well, I think if the axial length is normal for that age, then I'm not going to be worried about the glaucoma. There's not going to be any active glaucoma in all likelihood. The other thing is something that I've always done is, when you look at these corneal opacities, there should be no epithelial edema if there's no glaucoma. And if you press lightly with a forceps, if you have an indentation left, there's epithelial edema. So even if your axial length looks like it's normal, if there's epithelial edema, then there is pressure, and you have to deal with that. I have published about using high-frequency ultrasound to do cyclodiode laser, and I pick off the ciliary processes. And people think that this is destructive. It is in adults, but in infants, I can show you time and time again where the ciliary epithelium seems to regenerate. So all I do is buy time so the child is old enough and the anterior chamber deep enough for me to put a tube in. Sometimes I'll do the laser, get the pressure control, do the graft, and then warn the parents that I might have to put a tube in afterwards. But at the time of the surgery, the pressure's controlled.
I just want to make one comment just about the diagnosis of glaucoma. You also have time. So with glaucoma, if the pressure is normal, again, the pressure may not mean anything in these patients with these abnormal corneas, but you would expect time. So our EUAs include the corneal diameter, axial length, everything we've talked about, but you have to see where they're falling on the curve. And a lot of the time when these, you're unclear, you'll find that the rate of change is increased and they really do have glaucoma. So if you're not sure at one point, schedule another EUA soon enough and you compare the 2 points, and it'll be usually my experience is very clear that you're getting an abnormal rate of growth and you do need to do something.
So the Perkins actually may not give you accurate values, right? When you're measuring in these dense scarred corneas or very thick corneas, it will not give you good values. And I think digital pressures are what you looking at whether the child is symptomatic or not. Sometimes, but not all of these kids with corneal opacities do have the blepharospasm, that or lacrimation that you find with normal PCG patients. But I think what everybody mentioned about, spacing out the EUAs, and you'll have a better idea of whether there is a component of that or not.
Yeah, we'll move on to next talk. Mal will be delivering on surgical considerations for the keratoplast. Unmute, please, Dr. Mal. Dr. Mal, yeah.
Yeah, got it. I thought it was unmuted. Yeah, so we've been listening to the previous speakers about the different conditions that we come across and trying to figure out, what are the factors that determine when we should be operating these patients and what are the investigations that we need to do. But the important things that we need to look at, as Dr. Asim Ali was mentioning, and Ken before that, was the visual function and the visual potential of these kids. And then understanding what you should do if you have a bilateral condition with symmetrical opacities or a bilateral condition with asymmetrical opacities or a unilateral condition, and then factor in the age of the child there, because if they've crossed the amblyogenic age, then obviously anything you do for a unilateral case is not going to help the patient to regain useful vision. And what we've also understood is that if they have associated ocular pathology, particularly glaucoma is what hits these kids, is that we have to tackle that first. And if they have a lens involvement, any associated surgery with the transplant is going to affect that adversely. But finally, it all boils down to the motivation, compliance, and the socioeconomic status of the family, because it's not just a child that we're operating on, it's the whole family that gets involved, and it's an entire team that is required to deal with these kids. So therefore, the counseling becomes paramount, making them understand what it entails. There are a significant number of follow-ups that are required, after the surgery. Several number of examination under anesthesia. So now the choice of the surgery would depend on the anatomical location of the opacity and the layer involved. So sometimes we may just get away with mydriasis, particularly when you have an opacity that's not as dense, not involving the visual axis significantly. And if it's a unilateral opacity, that may be the way to go. Often we resort to doing iridectomies, and this is a patient who has had an iridectomy more than 7 years ago, and he's maintaining good vision of around 20/40 in this eye, and you realize that the opacity over time does tend to fade. The other option, if you have involvement of just the stroma, so this is a patient with mucopolysaccharidosis who did not have endothelial involvement. So here you would resort to doing a DALC as opposed to doing a full thickness graft. And if you have the endothelium involved, like in any of the CHED or PCD, then you would, depending on the density of the opacity, whether you can see the anterior chamber or the iris details, you would decide about doing a DSEC or a full thickness graft, as the case may be. And in certain instances where you have a patient with ASDA or Peters anomaly, as we often call it, then you may get away with a SEPA, either combined with an optical iridectomy or with a lensectomy or just alone. And over time, the endothelial cells tend to grow over that defect that has been created once you've removed the abnormal cells that are preventing migration of endothelium, and that tends to clear up over time. So, so the trends in children have not been the same as in adults, and you realize that we still do a lot more transplants in full thickness grafts in children as opposed to adults, where we are slowly shifting to doing a lot of endothelial keratoplasties. And I guess this is going to be a sustained trend for some time, because the kind of anomalies that you do get do not allow you to do lamellar surgeries too frequently. Now, what's important when you're looking at a transplant of full thickness graft in a child, it's important to have a very good quality donor tissue, preferably with an intact epithelial surface with a very good endothelial cell count, and try and age match that as much as possible. The other thing that we need to look at is what are the issues that we're likely to face when doing surgery in these kids? Because like Dr. Ali alluded to it, it's technically more difficult in these kids. They have a smaller anterior segment, so smaller space in which to manipulate. There's a greater amount of iris plasticity and vitreous tenacity, so increased amount of inflammation. And also, because of this decreased scleral rigidity, there is a tendency for scleral collapse, positive pressure, iris lens diaphragm shifts forward, and the lens tends to get expelled. And obviously, like I mentioned earlier, if you lose the lens and you have to do a vitrectomy during the surgery, then the outcome of this graft is going to be much, much poorer as opposed to if you had to have a lens and iris in place. So the team involves a pediatric anesthetist who has to be well versed with giving anesthesia in these children. And we use non-depolarizing muscle relaxants, try to keep the children pretty deep, maybe use a super pinky or a digital massage. Sometimes we use a peribulbar block, but very limited amount of anesthesia, and then do a digital massage to try and get the pressure down as much as we can. And we tend to give a small bolus dose of mannitol that also helps. And like I said, a minimal peribulbar block. Sometimes intraoperatively, it may help giving a bolus dose of mannitol. We just give about 10 or 20 ml depending on the weight of the child. And that tends to help, especially when you have the iris bulging forward. If you have a small palpebral aperture, then a lateral canthotomy does help relieve pressure on the tightness of the lids. That works. We should also use, speculum that does not cause additional pressure on the sclera, and the pediatric speculum or even lid sutures are very beneficial in that aspect. And the Fleringer ring. So a lot of surgeons use a Fleringer ring, and this video is not going to run, I think. So we use a Fleringer ring basically to prevent the scleral collapse, and this has to be done equidistant all around, going through the episclera and having these long sutures that you can use, which you can tape onto the brow or the cheek, as the case may be. And we request the anesthetist to hyperventilate to, increase the carbon dioxide washout during the surgery. So when you look at the type of instrumentation, for the donor, you can use a trephine, which could be either, it could be either Gilton trephine that we use or a vacuum trephine. Ideally, punch the donor before the recipient because of the, there's a very high chance of the thrust during surgery and the lens could get expelled. And using a 0.5 or a 0.75 millimeter larger trephine for the recipient, so that you have a larger space in the AC that is created. And there are different techniques that I'll come to later to describe what is being done. Usually we go 3/4 of the depth and then try and do a slow decompression, enter into the AC, and then move on with the remaining part. So what's also important is to ensure that you use copious viscoelastic during the surgery, and ensure you can do a couple of peripheral iridectomies. I'll show the full surgery in this particular video. So this was a child who presented to us with DeBarcy syndrome. She had premature aging. This is about when she's a year old. She had a vascularized corneal scar in both eyes. And here we're doing a slow entry into the AC using the right and the left corneal scissors to make these vertical cuts. We have to make sure that the edge is not too is straight, if we can possibly achieve that. And then either use the same blade to complete the whole thing, or sometimes you may use the other side. If you've already punched the donor tissue before doing this, then you would transfer it immediately without much of a gap between, and then use interrupted sutures using 10-0 nylon. In this case, we've taken, I think, a 0.5 millimeter difference between the donor and the recipient. And I haven't used a Fleringer ring for this particular case. I don't use it very frequently, but in patients who are vitrectomized, aphakic, longer action lens, previously done a glaucoma filtering surgery, then probably would want to use a Fleringer ring in those instances. And the aim would be to try and make sure that you have interrupted sutures, AC well formed at the end of the procedure. The wound is watertight when you close, and check that with a surgical sponge. And sometimes if there's a wound leak, you may have to use an additional suture. Here we put a bandage contact lens because the epithelium was not intact, and it's important to have an intact epithelium during the surgery. So what we've realized is when we're using tissues that are stored in Optisol or Cortisol, when they're around 10 days or a little beyond, then the epithelium does tend to slough off. So probably one of the things we could look at is having a shorter duration in the preservation medium. So when there's a threat of expulsion, theoretically, you could use bridging sutures, a lens loop, start using 8-0 nylon and replace that. The use of myotics is doubtful, but what I've come across in literature, though not used it myself, is a sandwich technique. So what was described is that if this is the recipient cornea, which is opacified here, you don't remove the entire cornea, you cut it in quadrants and then place these 4 sutures with the knots exposed. And over this, we would place a significant amount of cohesive viscoelastic. And over that, the blue line here I've used is to denote the donor tissue, which goes over it. It's secured with 3 sutures. So you have a sandwich. The recipient tissue, which has been cut quadrant-wise, and sutures placed that the intraocular contents are not allowed to bulge. And then you place the donor tissue over that. And then subsequently, what you do is you release the sutures which are anchoring the recipient tissue and pull it out through 1/2 after you've anchored the donor over that with a couple of sutures. And then you ensure that you maintain the chamber that way, and you have a very, very less chance of losing the lens. So the associated procedures that we may perform are lensectomy, a vitrectomy, a syneculisis, and peripheral iridectomies or pupilloplasties. Important to have a good mid-dilated pupil if you're going to kind of enlarge it, and preferably don't use or don't try and reduce the size of pupil because it's important to be able to see the fundus subsequently. In patients where it's possible, we would prefer to use a lens if there's an associated cataract, we have to do that surgery. But in summary, when you're doing the surgery, it's pretty challenging. I'm not covering DSEC or DALC or SIPA in this. I've restricted it only to the full thickness grafts. And the surgery per se is pretty challenging because these are not the same as small adults. It's the beginning of a very long and arduous journey because doing the surgery is just the start. And you realize as you follow these kids up, that it's not a smooth course. It's a road which has got lots of obstacles and lots of ups and downs. And managing to keep that graft clear is something that all of us struggle to attain. Thank you.
Thank you, Dr. Mal, for a very informative presentation. And you brought out, several, the succinct points, dealing with pediatric peaking and kind of technical complications one can actually encounter if we do not preempt and prepare it well in advance. Dr. Ken and Dr. Radhika, any question, comments? You do anything different?
I think that was an excellent talk, and it talked about the pitfalls that you can run into. I mean, I use a Fleringer ring. I know that Merle doesn't, but I think people who are starting to do these, it's probably safer to use a Fleringer ring. But when you're as experienced as Merle and the other surgeons on this panel, you probably don't need to. But I think all those are all really good tricks. And the thing about anesthesia is that your end tidal CO2 has to be around 30. We adjust, the paper has now just been done to show, we're just publishing it in the anesthesia journal, that when the end tidal CO2 is 40, your choroidal thickness is almost double what it is when it's 30. And it's the choroidal thickness that transmits pressure through the vitreous and causes positive vitreous pressure. And we also we measured the intraocular pressure at the same time with an pneumatonometer, sorry. And the pressure rise is extraordinary. From 30, it is around 10. on average. Then it goes to 25 on average. And then when you hit 50, which is what they often will run at in some children, it's as high as 40 or 50 intraocular pressure. So I think that's a very important thing to remember, to do paralysis with end-tidal CO2 that's low. Or as low as it can be for the child's safety.
Sure. So one of the caveat of using a Fleringer ring is whenever you have a post trap or a post valve or you have a spiral thinning. So do you avoid or do you put a rings there, Dr. Ken?
I use a C, not a ring.
Sure.
So the C, the open segment is where the tube is or where the bleb is. So that I still put sutures, but I have a modified Fleringer ring.
Okay. Thank you. Thank you. If there are no questions, we'll move on to the next talk. I'll invite Professor Arif Khan. He'll be talking when to avoid corneal surgery.
Hello, can you see my screen?
Yes, sir. Yes, sir. Please go ahead. Thank you. Thank you for joining us.
Yes. Well, this is a great symposium. I've really enjoyed the talks. Thanks for including me. And thank you in particular for including this particular topic. On this symposium, we've heard a lot about different surgical techniques and the complications and indications. But I think it's important to have a talk like this in a pediatric corneal symposium about when not to do corneal surgery, because as we just heard from the previous speaker, Dr. Merle, once you open that door of surgery, it's a long and arduous journey, and you don't want to open that door unless you really have to. So I don't think there's any debate if a child comes in with bilateral congenital corneal opacity and the eye otherwise is grossly normal inside, a corneal procedure needs to be done for the child to have vision. That's not the debate. But there are situations where a child comes in with congenital corneal opacity, and it's important not to do corneal surgery. And one big reason, actually, I know all of the speakers know about this, but it hasn't been highlighted yet, and that's my first point, was what I want to highlight, is when the patient can be actually refracted despite the opacity. Everyone who deals with children with congenital corneal opacities either has to be familiar with the retinoscope or work with someone who's good with the retinoscope. Because if you're not doing that, you're not giving these children optimal care, and you're not avoiding corneal surgery when it could be avoided. Here's a newborn referred for corneal surgery. Certainly those opacities look quite significant in both eyes. But interestingly, some congenital corneal opacities look quite significant in diffuse illumination, but actually optically they're not that bad, or on the slit lamp they're not that bad. There's some interesting refractive things that can happen with some of these corneal opacities. And in this particular case, we can refract this child very well, even though those opacities look quite significant in diffuse illumination. This child actually has a condition known as cornea plana. Now, cornea plana is an interesting phenotype with characteristic features, but one of the variable features they have is this variable corneal opacity, where it looks very significant in diffuse light, but actually optically it's not that significant. Cornea plana, again, it's a very distinct phenotype. I'm not going to talk about the classic appearance, but this corneal opacity that they sometimes has is so interesting because, again, in diffuse illumination, look at these pictures I'm showing you here. That looks quite significant. But these children that I'm showing you here, they can see quite well, 20/40, 20/30 with the proper refraction. And you see on the slit beam there, the opacity is not as bad as it looks in diffuse illumination. So you almost always must assess these children with the retinoscope, not just depend on diffuse illumination. Not only assess them with the retinoscope, but assess them with the proper lenses, because any child who has a high refractive error if you look at them with the retinoscope, the reflex will be dull. It's not always from corneal opacity, even if there's an opacity there. Sometimes you put up the refractive correction and you can see how it really, really sharpens. So this is very important in assessing these children. Here's another child referred with corneal opacity, unilateral congenital corneal opacity, referred for surgery. And you can see that opacity in the left eye. But when we use the trusty retinoscope, it is quite optically sound. You can get a good refraction, you can get a good reflex. And this patient was managed with refraction and patching and did quite well. And as the child got older, the opacity actually cleared a bit, but it was never optically significant. Could not have determined that without using the retinoscope and putting up the hyperopic lens. Again, just doing the retinoscope without putting up the hyperopic lens after cycloplegia, it would look dull, but putting up that lens, it really clears up. Surgery not needed for this patient. Here's a child again. You can see those corneas look pretty bad in diffuse illumination, but that bluish color actually suggests what the diagnosis is already, at least in my experience. And in this patient, again, the patient can be refracted. This patient has congenital hereditary endothelial dystrophy. Now, some of the patients with CHED do have very significant opacities that cannot be refracted through in childhood, but not all of them do. There's a lot of variable expressivity. So we have to make sure that refraction is not the real treatment they need before we go on to corneal surgery. Here's a child, again, referred with corneal opacities for surgery. Again, the opacities look worse than they are in diffuse illumination, look worse in diffuse illumination than they act with refraction. And this is a child with mucopolysaccharidosis. Now, of course, again, just like CHED, children with mucopolysaccharidosis can get visually significant corneal opacities that require surgery. But first, we have to make sure there's not a refractive error there, that it's not something that can be refracted, because even if they do need corneal surgery, as we've heard from several speakers, the longer we can delay that, the better the prognosis for the children. Here's another child, looks pretty bad, and we've heard this diagnosis a couple of times. It looks pretty bad, but actually the child can be refracted. And this silvery cornea is a sign that the patient has primary aphakia. And you've heard from several speakers, it's a no-no to do corneal surgery in these patients. And many of them can be refracted. So even before, realizing that it's primary aphakia and surgery should be avoided, if we just try to refract the patient, we can see that the patients do improve with refraction, and the opacity is not as bad optically as it looks in diffuse illumination. The second time, or the second concept that I'd like to share with you where we do not do corneal surgery is that a peripheral iridectomy is feasible. Because when we enter into corneal surgery into these very young children, we're opening a door of a lot of follow-up, potential for complications, a lot of anesthesias. And if we have another way to do it that doesn't involve all of that follow-up and anesthesia, it's preferable. There's a newborn girl with a dense corneal opacity, visually significant. There's actually lenticular corneal touch as well. But this is a unilateral case. There's a very good, segment of temporal cornea there. This is a great situation for peripheral iridectomy. And particularly in my patient population, because if you're going to embark on a corneal surgery, you really have to have a family that is dedicated, can keep the follow-up, can stay on top of things, because if they don't, it's destined to fail. So especially have your family that may not be able to be involved in the intense management or follow-up, or don't understand the degree of it, optical iridectomy is really, really a great procedure. And this family did quite well with the optical iridectomy and has quite functional vision. Always think about peripheral iridectomy, especially in the unilateral cases where amblyopia is an issue. You can get equal or even better vision than had corneal surgery been done. It's another situation, 2-year-old boy. He's got achondroplasia. He's very hyperactive. He's got a corneal scar in the left eye. It's hyposensitive as well. He's got esotropia also from amblyopia. it would really be a major project lifelong for this child or throughout his childhood if you were going to embark on a corneal surgery in this patient. Peripheral iridectomy is a great solution for a situation like this. Here's a patient for whom peripheral iridectomy was recommended, went on to have corneal surgery with another provider and really had many complications. I mean, anyone, even in the best of hands, we can have complications in these situations. We want to try to avoid corneal surgery if we can. The final concept I'd like to share with you about when not to do corneal surgery. If there's dense refractory amblyopia or the expectation that surgery will fail, we have to look at the patient in totality and not just operate on something because it's there. We really have to consider what is the visual prognosis and what is the chance for complication and failure in these children. It's always a risk versus benefit decision. This takes judgment. This takes experience. It takes discussion. The presence of ocular comorbidities and unilateral disease are situations that might push you to not offering surgery. I mean, this is a patient who had a unilateral opacity, multiple surgeries, failures, infections, had something like 20 general anesthesias in the first 2 years of life, started to have self-mutilating behavior, and I suspect it's related to all of these anesthesias that she went through. What are we doing to these children? We have to really understand that just because something is there doesn't mean it needs to be operated on. We have to realize when we're opening the door to multiple complications, if the prognosis is poor, we have to step back and do what's best for the child. You know, if you have a patient who has significant amblyopia or significant morbidity, other ocular morbidity, doing a corneal transplant is not a service to a patient like this. Really, the goal is just to try to preserve the eye. We don't want to open that door of what corneal surgery entails in terms of follow-up unless we really have to. So that brings me to the end of what I wanted to convey. Thank you so much for allowing me to speak about this topic in this session. I think it's very important for us to talk about not only how we manage corneal opacities and the different techniques we have, but when not to do corneal surgery. So thank you very much. I'll stop with that.
Thank you, Dr. Arif. It's a beautiful talk and a very, very, pertinent message. And as we understand, as a young clinician in the early phase of our career, we tend to be much aggressive. We tend to, go after every case when we see. And perhaps it may take 10 to 15 years of experience when not to do a surgery. Is there a way we can cut short that learning curve?
Well, I think we should speak to colleagues always. If it's a corneal specialist, speak with a pediatric ophthalmologist. This issue of the amblyopia and the unilateral cases, you really have to have a dedicated family. There was the discussion earlier on about unilateral, whether or not to operate on unilateral opacity if the other eye is completely normal. I mean, this is so dependent on the patient, the family's understanding of the situation and their willingness to embark in this. In my experience, in my patient population, I would be very, 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 very reluctant to offer or suggest unilateral surgery. Now, you can have different dynamics, different families, different education levels. You really have to take that into account. But I've seen, unfortunately, many families go through a lot of suffering with their children and multiple general anesthesias when the prognosis was very poor to start with. Just because something is there doesn't mean that it needs to be done. I always tell the residents and fellows that the hardest decision for patients is not to do surgery, but not to do surgery. That's the hardest decision.
Well said. Absolutely. We'll quickly move on to the next talk. Gives me great pleasure in inviting Professor Deepak Edward. He'll be talking to us on a clinicopathological correlation.
Okay. Well, thank you, Dr. Murali, for inviting me to this very nice symposium. I've learned a lot. And so I'm going to dive right into the topic, and I'm going to be talking about clinical pathologic correlations of some of the corneal opacified corneas that we just spoke about, and also some of the controversies and what we don't know. So this is kind of the outline of my talk. A few words about the embryology of the cornea. I think most of the participants know this, that the corneal epithelium, here's an embryo eye, comes from the surface ectoderm. The cells in the stroma, the keratocytes, which are coming here as a wave, these come from neural crests, and so do the nerves in the cornea. At around 12 weeks of gestation, there are about 2 layers of epithelium and 2 to 3 layers of endothelium, which eventually become monolayered as the child approaches birth. We know a lot about the diameters, the thickness of the cornea in infants, preterm and term infants, so the epithelium is very thin. The corneal stroma is much more cellular than it is in the adult cornea. And of course, the Descemet's membrane is very thin, and I think one needs to remember this when we talk about children who have congenital glaucoma and also CHED, which is the different end of the spectrum, and there are a lot of endothelial cells. We don't know a lot about the physical characteristics of the corneal stroma or the biochemical or molecular structure of the corneal structures in infants or children. We just don't know. And I think that's part of the issue when we deal with corneal opacification. One thing we know is that the corneal stromal collagen is not very well cross-linked in a child, and that's why wounds gape. You don't suture a paracentesis, it leaks, and that's because the cornea is not stiff enough, it's elastic. Also, the number of elastic fibers are much more in a pediatric cornea than an adult. So I encourage some young people to take this up as a challenge and study this topic more extensively. So diving into corneal opacification in children, we've heard a lot of talk about Peters anomaly, and I think I can skip this slide. We'll just dive into the pathology. So here are some specimens, pathological specimens. As you know, that the stroma is thin centrally. You don't have that caved, inward caved-like appearance. Descemet is often absent centrally, and this is an example of a Peters type 2, where the lens is actually, this is the lens capsule adherent to which can be adherent to the posterior corneal surface, which lacks any endothelial cells or Descemet's membrane. Here's another interesting example. This is again a patient where this was an autopsy eye, which I happened to see, and the child was, had passed on. So I was called to see this autopsy patient who had a corneal opacity. And this patient actually had a chromosomal abnormality, not the usual Peters genetic defects. But interestingly, again, you can see you have the whole eye now, and you see the iridocorneal adhesions here. You see the absence of central Descemet kind of here. But you see at the edge of Descemet, which comes somewhere here, are these aggregates of cells. They've stopped here at this edge, and they don't move ahead. There's some sort of inhibition. And I think Dr. Murli and I have talked about these cells, and if you kind of scrape them off, and that may be the reason why some of these cells cover this gap when you do a procedure like an endothelicectomy in Peters anomaly. I'll touch on the angle a little bit more later in this talk. So one of the things we need to understand is, all corneas look scarred, but they're not similar. We published this paper many years ago looking at the pathological and immunohistochemical changes between corneal opacification and PCG and Peters. These are graphs in these patients. Bottom line, they're different. Both the immunophenotype in Peters is very different from that in congenital glaucoma, and those from other forms of corneal opacification. So there is a scarring component, but we really don't understand how differently the cornea in a child behaves in terms of a pathological or molecular sequence compared to an adult. We've talked a lot about sclerocornea. I'll leave the clinical part, for you to read. But I think the pathology is very interesting in the subject. So when you look at a patient's cornea with sclerocornea, of course, the epithelium can be normal. Most often, Bowman's layer is absent. The collagen fibers are irregularly arranged, and the stroma may show normal clefting. So why is the cornea so opaque? So, for example, so here's a normal age-matched cornea of a normal eye, and this is sclerocornea. So the scleral fiber, the corneal fibers are very thick, very similar to what you see in the sclera. So on light microscopy, they kind of look like sclera, but is it really sclera? And so the answer is no. It's really corneal. Keratin sulfate, as all of you know, is the major glycosaminoglycan expressed in the cornea. So if you look at this patient with sclerocornea, there's normal expression of keratin sulfate in the cornea. It just happens that the processing of collagen fibers as they form in childhood is different. And I don't have time to go over the molecular pathology of that, but there's abnormal processing of the fibers, which is influenced by keratin sulfate, and that's why you get this scleral-like fiber. So it's cornea, looks like sclera, but it's really cornea. Lots been said about CHED also, again, and when we come down to the pathology of this condition, you might see, basal epithelial swelling that's been talked about because of a dysfunctional endothelium. The corneal stroma shows edema, and of course there is, a loss of endothelial cells and a thick decimate. So here, in comparison, at almost same magnification, is a normal corneal decimase membrane and endothelium, and this is one in CHED, shows a massive thickening of decimase and very thin endothelial cells, or paucity of endothelial cells, which sometimes can focally be multi-layered. Sometimes they differentiate into melanocytes or fibroblast-like cells. So they're not normal-looking endothelial cells, despite them being attenuated. Their EM and staining appearance is different from normal corneal endothelium, and you can see why removing this layer and replacing it with a DSEC-like procedure helps the cornea. Corneal keloids is an interesting topic, not that common, but this is a exuberant proliferation of fibrotic material in the cornea, and there can be different inciting factors. So here are some pictures in collaboration with the Path Lab at LVP and others, showing you some of the features that these corneas can show. So in the area of the keloid, of course, this is, if you can look at this picture here, normal corneal stroma. And here, all of a sudden, there's an abrupt change or difference. This is a DALK specimen, because that's why there's no endothelium, and kind of a loose corneal stromal appearance, because there's a lot of glycosaminoglycan in this area, and that's potentially also responsible for scarring. It's not just collagen. There are fibroblasts, which are irregularly arranged. Again, a Masson trichrome scan showing you the interface, a very sharp interface between the abnormal, the normal stroma and the collagenous stroma of the keloid. So vessels, and here again, you see the demarcation here. So it's not all collagen here. It's also abundant mucopolysaccharide. So another interesting finding, if you look at these fibroblasts themselves, we think of keloids as being very, very active. So when you remove these keloids and do a smooth muscle actin stain, which stains myofibroblasts, which are proliferating cells, in the area of the keloid, none of these cells stain. So the fibroblasts, at least at the time when these were removed, are not very active. Clinically, I think, but not proven point, is that at the base of the keloid, often you have very active cells, that's the base, or at the edge of where it's removed, it's very active. So some of the clinical points may be, again, not proved. And here's another one showing the edge of the keloid having a lot of actin, is that you want to take out more stroma than what you can see clinically, just maybe a little wider margin to prevent recurrence of the keloid. So mucopolysaccharidosis, we've talked about this also. So there's some interesting issues in mucopolysaccharides pathologically. All of us know that the cornea is really, really thick in these conditions. It gives headaches to glaucoma specialists. I kind of wear both hats. But interestingly, so this is one of the corneas on your right, and we'll go on or the left one in a minute, this is a PKP in a specimen with Hurler syndrome. Notice, the corneal stroma looks a little irregular. The collagen fibers look a little irregular, but the cornea was very cloudy. And when you do Alcian blue staining, which shows mucopolysaccharide deposition, obviously this amount of deposition of mucopolysaccharide is not enough to cause that markedly thick cornea. Here's some pictures of a very nice paper out of Mass Eye and Ear Infirmary showing you corneal pathology. Again, not very impressive mucopolysaccharide stain. And for Ken's pleasure, you can also see this clefting and staining with Alcian blue in these clefts in the cornea, very prominently seen in MPS. It's one of the features that you can see in this cornea, but not always. So showing you clefts with mucopolysaccharides in them. So coming to a congenital primary aphakia, so I had the privilege of working with Dr. Chaurasia and Dr. Murli on this paper, just to show you why the grafts fail in these children. The answer, it was kind of interesting why these eye go into phthisis. So here you see a cross-section through a cornea, and like to pay your attention to the posterior surface of the cornea, which has no endothelial cells or decimes, but oh, what is this? This is ciliary epithelium lining the posterior layer of the cornea. Here's another eye. Again, these were from twins from Dr. Murli's practice. Both the eyes went into phthisis. And here in the PKP, you see ciliary body, which has not migrated posteriorly, attached to the cornea. So if you do a graft in this, you're most likely taking up the source of aqueous humor, production in this eye, and predisposing these patients to phthisis. So I'd leave it up to many people to try and think how you can treat these patients who do develop glaucoma. In what way would be the best way to treat them? Congenital glaucomas, we've all touched on this and talked about it a lot. And here, Hofstria, just to show you the pathologic correlate, the edges of the defect are curled decimes membrane. And of course, we all know about the corneal edema. And what kind of I don't understand is how these corneas clear up so fast, right? I told you there are a lot of endothelial cells, but when you lower the pressure, often the cornea clears. There's still a defect, again, subject for discussion how they clear. But this points out to the point where Dr. Mundell brought up that the endothelial cells in these patients often are greatly decreased. This is a specimen from a 45-year-old patient with PCG whose corneas are pacified. And you can see most of the endothelial cells are gone here. So they do have a lot of loss of endothelial cells. And the cornea overlying it can show some degree of scarring. So we talked about other abnormalities. I'll come back to this eye here, showing you the angle itself right here in the periphery. And what you see at high magnification, low magnification. In this particular eye, the angle, again, this is was about 34 or 35 weeks was autopsy eye. You can see meshwork has formed somewhat. The angle is still not matured, and Schlem's canal is completely absent in this eye. So you can see why some of these eyes are predisposed to developing glaucoma because of anterior chamber angle anomaly or dysgenesis. It's an incomplete maturation of the angle that can happen in these children. So in conclusion, the developing and pediatric cornea has unique features. Much remains unknown, even in the normal cornea. Corneal opacities in children have many causes. Pathological features vary. And I think we really need to understand this disease much better pathologically and downstream in order to develop new therapies or new approaches to treatment. Thank you very much.
Thank you, sir, for excellent talk. And you actually helped us, particularly when it comes to congenital aphakia, to answer why these eyes, go into phthisis following a penetrating keratoplasty. Apart from what Ken was, alluding to, abnormal vitreous, we are in fact, taking out the ciliary processes. Hence, they may not able to maintain the, the anatomical integrity, thus, end up having a phthisis bulbi. Thank you once again. Are there any questions for Professor Deepak? Dr. Ken?
No, excellent talk as always, giving us sort of insight at a microscopic level as to what's going on. I don't know that. So it's interesting. When I read this paper, I went back to Great Ormond Street to the pathologist there, and in the 3 cases that I did, the button didn't have ciliary epithelium on it. So I think that's definitely one mechanism, but in those 3 cases, they developed this sort of cyclitic membrane which sort of pull the retina off. So maybe there could be a combined mechanism where why these eyes don't do well. But for whatever reason, we didn't see ciliary epithelium on the button. It could be that it had fallen off.
Yeah, so Ken, some of these eyes, that cyclitic membrane that you see, the epithelium loses in some areas the normal features, the ciliary epithelium, when it adheres to that. So if you want to go back, and we can talk offline of some stains you can use to distinguish the cells that line that posterior layer. That may be interesting to look at. Yeah.
Thank you. Yeah.
Also, in one of the specimen, sir, if you remember, there was a retinal tissue. Basically, your landmarks are indistinct. Although we believe it is a cornea, we are probably going much beyond, ciliary body area.
Yeah, so what happens developmentally, if you remember your embryology, everything is more anterior, right? As the eye is developing, both the angle recess as well as all the structures, and as the eye grows, everything is pushed backwards a little bit. So, and that's probably contributes to getting retina and other structures more anteriorly. Thank you.
Thank you, sir. So last but not least, now one of the important talk, I'll invite my dear friend, Dr. Ramesh, to talk about the post-operative management. This is more critical, and also, journey of new rehabilitative journey, particularly during neuroplasticity. Over to you, Dr. Ramesh. Sorry for the delay.
Yeah, thank you, Murli. I know it's the last talk. This is something where I do not do a single corneal surgery, but I do manage some of these patients together with our corneal team. Just wanted to share some of our experience, and happy to share it to everyone. And we always hope good always prevails. Just wanted to share, Eli Prasad had completed 50,000 corneal surgery very recently. Being a part, if you look at this picture here, that represents, it's not only the corneal surgery, even beyond that, the refraction, the rehabilitation, everything matters. It's not just the surgery that represents, this design represents everything here. So in a child, there is a sensitive phase and a critical phase. Always we thought that critical period, during that time we have to do it. But even in cataract and much more in corneal opacities, delaying the surgery in that sensitive phase makes sense in terms of safety and in terms of development of future complications, and in terms of giving better vision, because the better developed anterior segment and the eye provides the long-term success in terms of corneal graft clarity and things like that. And we always know eye is a kind of a window to the brain. And if you look at this child, children are desperate to see. Whatever you give that window, either through a graft or through an optical iridectomy, or even through the glasses, they will try to do. But just looking at, I think Dr. Arif and Asim Ali has made the talk simpler. We cannot apply the same thing. Here you can see the bilateral cataract surgery done, surgery on time, and the child is fine. And the same thing if you apply, this is the delayed cataract surgery. Whatever you do, it will still improve, but we know that touch always cheats vision. So we have to have a balance between the waiting period and surgical time. And it's much more in terms of bilateral disease because it can really affect the development of a child. Having said that, some of those severe cases, conservative management, waiting for 2 months and then re-evaluating after a month, doing all the imaging studies, looking at the brain, again waiting, we can still give a reasonable vision for this patient. For this patient, these are the 5 things we need to look at. Corneal or the lenticular or whatever pathology you see, either conservative or surgical. Once you do this surgery, you open that whole thing for the complication or even vision and everything. These are all a part of this surgical consequences. Immediately refractive and amblyopia management. And never forget, there is something which can be associated with corneal disease, especially macular and optic nerve. And also, some of these children can have a cerebral visual impairment component. That also, as a team, we need to take care. And sometimes external factors, like the earlier child had severe ptosis. The child was, in fact, lifting they know it, lift the eyelid, and then they can see. And even strabismus and nystagmus management, along with giving a clarity like this here. So this is one of the cases given a courtesy Murli. You can see it can become better from infancy to toddler. What you need is a very good refraction and some kind of early intervention in these kind of cases. These cases initially diagnosed as basket diagnosis of sclerocornea. You can see how they can become better. I think Dr. Arif Khan also showed a case, better weight. And again, refraction is something, it's very, very significant. If you look at this is a paper, I would not go into the details because it's a pretty old paper on optical iridectomy, how powerful it can be in unilateral versus bilateral in this paper, you can see. And sometimes there was a question whether in unilateral we have to do it or not. We agree with all the points. Sometimes I've seen children not going to school because of this kind of white eye. So that perspective also you have to take. And obviously long-term management of these kids has to be discussed. You can see here in this child, once you did the graft, it's not over. You have to give the glasses, and then they slowly develop this strabismus, and even the eyes look a bit different size-wise. So many things come later as well. So in terms of refractive correction, I think as Arif said, you either do the refraction yourself or work with some of the people who are good at it, because it's not a conventional thing. You can make the patient sit in one place. They will they'll cooperate for everything. You have to use different strategies, either in the examination under anesthesia or even in your clinical office. One thing with wearing glasses, we have to be careful is, compared to cataract surgery, aphakic or pseudophakic correction, here, most of the times, I'm not saying always, the first point is accommodation is quite good here. In cataract, the minute we take out the lens, we are also weakening the accommodation of the patient. However, even in pure graft patients, there could be a near vision issues, specifically because of pupilloplasty, the persistent dilated pupil. Sometimes they can have iris abnormality, which precludes the pupil from constricting and dilating. So You have to take a call depending upon the case-to-case basis, whether you will give distance vision glasses and also add the near. The glasses prescription becomes a little bit simpler, and which should be started as early as possible when the sutures are out, so that child will have the best potential. In terms of near vision, rarely in some of the cases of persistent pupillary dilatation, we might have to give. In terms of child's ability to see, the graft patients may be doing better than cataract because of two things. One is the accommodation, because the infants and toddler, their vision is at 1 meter or 2 meter. They are not looking at much beyond. So that may be better in this kind of patient. And these are some of the papers for your reference. In spite of the best efforts, what is the primary pediatric keratoplasty indications and graft survival and also visual outcome? Most of the patients' outcome may be poor, even if it is 20/50 or 21/60. It's a great thing. Even if you make a non-ambulatory patients to an ambulatory patient, I think it's a great thing. You have to look at, and this is important in counseling these patients. And this is another patient with the multicentric study. You can see the different outcomes of these patients. Anisometropia is a powerful risk factor, especially in unilateral. It can also happen in bilateral cases. This point was discussed. How do you really motivate the child? You know, this is something, it's not easy. The parents have to sit with the child and try to do all of this. Three things are important. One is moving things are better when the children are patching. Second thing is the colorful objects are better. And many things, people think in unilateral dense deprivational amblyopia, some of these dichoptic therapies will work. Unfortunately, in severe or moderate amblyopia, it does not really work. We have to go into patch therapy, and sometimes we can also go into pharmacological therapy. And the next two things are retinal. You always have to look at the retinal component if there is anything. As you can see here, there is a pupillary component also in this case. And also imaging, because this comes in the preoperative consideration. There are three things I will give utmost importance. One is for the brain, if there are any imaging issues, which is picking up anything on the brain. And second thing is systemic association, especially cardiac and renal. And obviously, any other genetic factors, obviously, after genetic testing, you will get it. And this is one of the beautiful paper which talks about MRI imaging findings and genetic testing results in children with congenital corneal opacities. You can see how many of these patients, you can see this table, abnormal MRI findings and abnormal orbit findings. Both can be there. Sometimes they can have a colobomatous cyst. All these things has to be looked into before you rehabilitate this patient. In terms of rehabilitation, as you can see in this slide, I have shown multiple of that. Some of them are testing to understand. Some of them are therapies which you should start immediately after any kind of intervention, either refractive correction or surgical intervention. So this is what you have to have a team where these early intervention modalities are available for these children in terms of visual stimulation, physiotherapy, and speech therapy and other things. So this is extremely important as you take care of this graft and other surgeries. External, I would not spend much time here. Give time, measure, remeasure the strabismus, try patch therapy, at least 8 to 10 months of stabilization, and then consider some kind of strabismus surgery, like in this patient you can see here, and even in this patient. And sometimes correcting this abnormal head posture also is very important in terms of giving their GEM a best possible vision. So as I said before, conservative management really works in some of the patients. And some of these children may need crutch glasses or maybe early intervention in terms of levator sling operation for this. So in summary, I think we need to provide a comprehensive management. It should not be just habit-based. It should not be profession-based. Oh, I am a corneal surgeon, I will do this way. We might take help from other people and also look at the availability and affordability of the patient. And finally, we should all practice evidence-based. And if there is a help in terms of, refraction and glasses, take help from the people who do it. Otherwise, it's best that we ourselves learn this so that comprehensive management can be there. One of the things I just always say is, how do you follow up these children who had surgery or some kind of intervention early? Always at every visit, try to do refraction, visual acuity, eye pressure, alignment, and amblyopia rule out. And also the second part is look at the lens, cornea, retina, or media. Whatever area you operate, look at those aspects very carefully. So do a real follow-up at every visit so that, okay, you might have a clear graft in both eyes, but you would have missed alignment. That could be avoided. So do a real follow-up at every visit. Even if this child had a kind of 4 millimeter cornea, came at probably 10 days after birth, but over a period of time, the child is doing well. You might have to do optos fundus photography. Sometimes you may not even be able to look at the retina and even gauge whether the optic disc damage is there because of glaucoma. All these things can be an issue. As said earlier by multiple speakers, it's a long journey. It's multidisciplinary, multi-speciality, and it will have a huge socioeconomic impact and also developmental impact on the child. And I just wanted to end with this photograph, courtesy Bhupesh. Look at this bilateral opacity, operated a little late, and over a period of time, they do very well with the good care on all the aspects. Thank you very much once again to all of you. And I know it's very late in the night. Thank you very much.
Thank you, Dr. Ramesh, for a real presentation. I like that real acronym. That's a strong message. Dr. Ken, Dr. Sushmita, any closing comments, remarks? I'm so sorry, we got delayed by 40 minutes.
No, I just want to congratulate you and all the panelists for what has been a very comprehensive and very interesting session. And I think, Ramesh brings it all home that it doesn't matter what you do, if you don't visually rehabilitate the child, it's a waste of time. It's a waste of time.
Thank you.
Thank you, sir. And I thank all the speakers for a fantastic, talks. Personally, I learned so much in the last 2.5 hours. And we didn't realize, the time actually went by almost close to 3 hours now. See you again during academy time. And wish you all happy Dashara.
Don't forget to go to the icon page on the WSPOS website. Please register your interest so that when we have our first meeting, we invite everyone to come and discuss a new classification system. Okay. Thank you.
Thank you.
Thank you.
Thank you, everyone.
Good night. Thank you. Thank you, Dr. Vinay.
Thanks.
Thank you.